Schneider Regional Medical Center, we are dedicated to providing high quality, compassionate care, and we are constantly focused on enhancing the patient experience. Our organization is embarking on an exciting digital transformation. We are adding new, cutting edge technology and, in many ways, transforming healthcare for our community. We are updating our electronic medical record, and we are preparing to participate in data exchange with other providers. We are implementing new clinical equipment and expanding our use of telemedicine to create new access to specialty care for our patients. Our staff and our patients are at the heart of everything we do. We are working to make Schneider Regional the best place to get care and the best place to give care. The changes that we are making within IT at our facilities will enhance both our staff's experience and our patients' experience. As we rebuild and modernize our facilities, we are designing for a brighter, advanced future where we use the latest innovation to help us deliver the best care to our community. We look forward to continuing to work with the Office of Health Information Technology, with Director Michelle Francis, and with other stakeholders to continue to advance health IT in the Virgin Islands.
Greetings to my colleagues and friends in the U.S. Virgin Islands. I am Dr. Garfield Clooney, the 123rd President of the National Medical Association, and it is an honor and pleasure to bring you remarks on behalf of the organization as you begin the U.S. Virgin Islands Digital Health Summit 2023. As many of you know, our region, your region, NMA Region 1, consists of the states New York, New Jersey, Connecticut, Rhode Island, Massachusetts, New Hampshire, Vermont, Maine, Puerto Rico, and the Virgin Islands, or the territory as I'm told it is called. We were recently there for our annual meeting entitled Achieving Health Equity for the Black Family at the Morningstar Bowie House Resort at the Westin Frenchman's Reef. It was a great meeting and we were treated very well by the folks at the resort. But more importantly, we had a great session on the Thursday afternoon entitled The Impact of the Public Health Emergency Unwinding and How That Impacts You, moderated by Mrs. Beverly Joseph, the Department of Human Services Expansion Services Coordinator, where the NMA doctors from the mainland had a chance to meet and hear from leaders like the Director of the Office of Health Information Technology, Mrs. Michelle Francis, Mr. Gary Smith, the Medicaid Director for the Department of Human Services, the CEO of the hospital, Ms. Tina Kamasiong, and Dr. Ty Hunt Caesar, the Chief Medical Officer of the U.S. Virgin Islands Health Department and founding dean of the medical school. They talked to us about the challenges the island faces, not only with the constituents losing valuable coverage due to the PHE ending, but we also heard from the group about the workforce challenges and clinical shortages that the territory is experiencing. As they say, technology is the great equalizer, and it is really an important tool to help address gaps in healthcare services and aid in smooth transition and coordination of care. I'm sure that during this Digital Health Summit, you all will generate ideas and solutions to meet some of these challenges facing the territory. And I'm here to tell you that the NMA stands ready to partner with the territory to help carry those concepts to fruition. I would like to acknowledge Governor Albert Bryan, who, by the way, has the exact same name as my only uncle on my mother's side. But in any case, I'd like to acknowledge and thank the governor for his leadership and attention to the importance of comprehensive, high-quality healthcare services locally. I'd also like to thank Dr. Brian Baycott, whom I had hoped to meet while I was there, but it just wasn't in the cards. But I would like to thank him for his leadership with the NMA U.S. Virgin Islands Medical Society. Lastly, I'd like to thank Drs. Lee and Cassandra Whitaker, who took a few of us on a tour of some of the medical facilities in St. Thomas and then took us to a very nice dinner. Now, we know Rome wasn't built in a day, but please know that the NMA is here and ready to partner and assist you all, our colleagues in the Virgin Islands, in carrying out your vision on what the ideal healthcare program would look like for the healthcare providers and people of the Virgin Islands. I look forward to continuing the conversation and hoping that the NMA members, maybe on the mainland, may be able to participate in the Digital Summit next year. Thank you again for the opportunity to bring comments. And before I close, I'd just like to inform you all that the National Medical Association's annual convention and scientific assembly will be held in New Orleans this year, July 23rd through August 2nd. And you can visit our website, nmanet.org. That's nmanet.org for more information. Thank you again and have a great meeting.
Good morning. Somehow everyone looks a little more sleepy than they did yesterday morning. How did that happen? Welcome back to the USVI Digital Health Summit 23. Because I forgot yesterday, I am remembering today. Behind me and up the stairs is a cafe. So in addition to the food, juices, coffee we have available, if you'd like a little something extra, upstairs this morning they had a carrot ginger Energizer Day juice. They will have watermelon and mint juice later on in the day. But please know that throughout the day there are snacks and beverages. Before lunch is served and in between breakfast. So hopefully everyone's ready to go. I feel like we should almost put on a soca song and make everyone dance. I won't do that to you yet. I will warn the gentlemen that there was a sock competition last year. And it was just because everyone was noticing, like all the ladies were dressed beautifully, but the men came with socks that just were like, what, out of this world. So men, check your socks today. There may be, Gary Smith is ready, there may be an award for best socks. I think we have to wait, Director Smith, though, until Brandon Richardson is here. He would be very bitter if we don't consider his socks. Thank you to the NMA for the comments they provided. It was exciting. We did not get to coordinate and plan with them when they came down, but hopefully in the future, that is a relationship we will be able to build. We see a lot of value there. I want to acknowledge SNC Telehealth. It was our oversight. We lumped them in with love to one of our gold sponsors, but we want to acknowledge their contribution to the Digital Health Summit, and thank you. I always like to pick on people, because it helps you wake up a little bit. I'll say, morning, Daryl Wade. Morning, Lauren. I had mentioned yesterday that Point Click Care is here in the U.S. Virgin Islands. They implemented Pulse, the Patient Unified Lookup System, and Tom. And just want to welcome you guys. There are a few resources that folks have brought. I'm not sure if Kim Tolliver is in the room, but she is the author of Revenue Cycle Management, Don't Get Lost in the Financial Maze. And I believe there's a copy of her book out at the front, and you'll want to find her as well. And Adam is going to be up from Clear Impact next after our first presentation, and you'll hear about a book that he's got here as well. So we're going to get started. Feel free to stand, stretch. We're going to jump in a little bit deep this morning, talking about the acronym is thrown out, HIE, with the assumption that we're all talking about the same thing. Then, if I were to pick on someone, I would say, what is define an HIE, not just health information exchange. What does it do? Then I might pick on someone else and say, what is a health data utility? And I'd like to see the look on everyone's faces, but I won't do that. Instead, we have an incredible group that's going to unpack not only what an HIE is, at HDU, but what is a shared services model? You heard that we have entered into, we've got an intention in the books with CRISP Shared Services to launch a pilot. looking at laying the building blocks for some basic interoperability, and just starting our journey to see, okay, can we get the pipes open and then can we connect them? So without further ado, I'd like to welcome up the CRISP team. And we've got some folks joining us virtually. Kat McDavitt, founder and chief strategy officer at Insenna. She'll share a little bit about herself, and Denise Sawyer to talk about DC Department of Healthcare Finance and their journey with a shared service. So welcome to the stage, our guests.
Thank you.
And I just want to make sure we might have you get, okay, welcome. We've got Kat, we've got Denise, welcome.
Welcome.
So I'm gonna have you guys share a little bit about your respective roles. Okay. No echo?
Okay. No echo?
So I'm going to have you share about your respective roles, because we've got 3 folks from CRISP Shared Services. We have Kat McDavitt from Insenna and Denise Sawyer from DC Medicaid Financing Team. So they'll share a little bit about their backgrounds. And I think Craig Beam, CEO of CRISP Shared Services, I will let you introduce your team, and then I believe that Kat's going to kick us off. Thank you and welcome.
Great. Yeah, that sounds great. Thanks for having us. This is a much larger crew and actually a more awake crew than I expected. So thank you all for being here. So I'm Craig Bam. I'm the CEO of CRISP Shared Services. We'll get into our perspective, what we do, who we are in a little bit. I have with me Ryan Bramble, who's our Chief Operating Officer, and has been with us almost 15 years, right, since the founding. And then Dr. Mark Rabner, who is a pediatrician by training and our Chief Medical Officer. So thank you. Kat, do you want to do your introduction?
Sure, thanks Craig. And hi everyone, Kat McDavitt. I'm partner and chief strategy officer at Insenna. We're a health tech consultancy. We work all over the country on different interoperability projects. Is there an echo or is that just me? I'm going to keep going. Let me know if there's a problem. But we work with 9 HIEs across the country. I'm beaming in from Atlanta this morning, so appreciate you all having me virtually. And of those 9 HIEs, several actually are working with CRISP Shared Services as affiliates. So I have an interesting perspective on regions where HIEs have chosen to go alone and HIEs that have chosen to join the CRISP Shared Services platform, and an overall collaboration with other HIEs across the country, which I consider to be absolutely top tier. So beyond that, I also represent about 20 private vendors that work in the interoperability space. I have a pretty broad perspective. The HIEs where I work with CRISP Shared Services range from Alaska all the way to Virginia. So definitely unique markets. Every market is very different, and I appreciate how CRISP has collaborated with those organizations to help them maintain autonomy and do what's right for their community. So pass it over to Denise now, who I believe is joining us from DC and has a lot of direct experience with CRISP Shared Services. Or I can tell jokes, Denise, you let me know.
There we go. Good morning, everyone. Good morning, everyone. There's a little bit of an echo. Let's do this. There we go. I think I was having some technical difficulties. Kat, I missed your intro completely. I only caught the bit about telling jokes, so I think I picked up my cue just in time to spare the audience. I'm delighted to be here. I'm Denise Sawyer. I wish I could join you all in person. I'm super bummed about that. But hey, greetings from the nation's capital, Washington, D.C. I'm the division director for digital health at the Department of Healthcare Finance, which is a mouthful. This department administers Washington, D.C.'s Medicaid program and also oversees the DC Health Information Exchange Marketplace. Through our Medicaid CHIP and the locally funded Healthcare Alliance program, we provide healthcare coverage for 40% of adults and 70% of children residing in Korea. Our agencies, particularly my shop and my wonderful team, we function as the state health IT coordinator. So a good kind of counterpart to Michelle Francis's office in the Virgin Islands. We lead digital health policy and strategy, as well as the implementation of HIE services in the district, in partnership with our designated health information exchange, CRISP DC, which is part of the larger CRISP shared services structure. We also serve as a convener of stakeholders through our DC HIE policy board, whose members are appointed by the mayor. We fund infrastructure, connectivity, and technical assistance in the district, and we also partner with our sister agencies to collaboratively govern and sustain HIE. And that's a little bit about us.
As Director
Sure.
Francis
Audio.
mentioned, there's an intention. There's an intention signed with CRISP Shared Services to start working on a pilot related to interoperability in the territory. So I'd love to jump in and ask Craig to talk about that and some of the details around it, because I think that's really exciting. When I first met Michelle, I said, it is such a blessing that you all are starting this work now, even though it may feel like a little bit later than some of the other regions in the States. But you're able to learn from both the lessons learned and successes of other markets. And I think it's awesome that you all have decided to collaborate with CRISP. So Craig, I'll hand it over to you.
No, that's great. Thanks, Kat. So maybe I'll start with a little bit of kind of history of HIE to get into then what the pilots look like. Because as you heard from Denise, HIEs can be very different in structure, in policy makeup, in governance, in funding models, and what we do is most of the technology side, but we also have a lot of experience in that diverse landscape. So HIEs traditionally, as they started 15, 20 years ago, were really about connecting providers with each other. We had electronic health records being funded through the federal government to really push out, new interoperability, new certified technology, new capabilities, and I think very wisely the then new Office of the National Coordinator and CMS and different folks said, well, it doesn't do us any good if you have these electric health records that are siloed. So let's also connect them with each other. And different groups, including CRISP, were started to connect hospitals with community practices and FQHCs and hopefully nursing homes, although as usual they were left out. And so that was really the history of our company, of where we started. We were a nonprofit established in Maryland first. I do get laughs when I say we actually are the Chesapeake Regional Information System for our patients, and somehow find myself on island and also in Alaska. But I guess Maryland the Chesapeake has broad reach. But so we did the hard work of connecting hospitals, and that means that we did real-time admission, discharge, transfer feeds. So we knew and still know when patients come and go from a hospital. We worked with practices to get patient rosters, so we know which of Dr. Rabner's patients, or which people are Dr. Rabner's patients, and then we could tell him about those patients. And you set up secure portals so that you can look up clinical information. And that really was the focus for a very long time, and that's the core of the technology part of an HIE. The other, probably more important part of an HIE is the governance, because none of this data flows without very thoughtful protections based on HIPAA, based on other types of data use in business associate agreements, and then based on the local jurisdiction, the policymakers, the policy board, the leadership that decides what's appropriate to send for what purposes, which we'll, I'm sure, get into a little bit. I do want to touch on a little bit, Michelle mentioned health data utility. So if we didn't have enough kind of acronyms and evolution in this part of the industry, we'll do one more. And before COVID, some HIEs, including CRISP DC, to their credit, were doing more work beyond the hospitals and doctors. They were doing work with Medicaid. DC pioneered a lot of work with things like their lead registry and their public school systems. And there was a clear acknowledgement that the same technology that would link a hospital with other doctors could also link a health department with a pediatrician, and could also link a school's absenteeism program with a hospital emergency department. Because these things, and as Ryan will get into, are really just matching patients and sharing data electronically and securely. So we moved into this new world of health data utility, which is the idea that when you build these connections one time and you have the infrastructure one time, you can reuse the data over and over again for all these different purposes, again, based on patient consent and policymakers determining that these are appropriate and necessary uses of the data. So that was a little bit long-winded, but hopefully it was helpful to kind of get us from 2006 to 2023 and beyond.
Sorry about that, I was on mute. But Craig, one more question for you and your team on, you mentioned nonprofit HIE and governance as one of the keys to success in communities. And so some of you know my background, very much private sector vigilante, and I believed that the private sector could fix any problems related to interoperability. And I did hear some friends from PointClickCare are in the room. PointClickCare acquired the company that I was working with that believed these things. And since then, I've come to find out that in various communities, they need different things, right? West Virginia needs a heavy focus on the opioid crisis. Alaska is incredibly focused on rural health needs and behavioral health, right? So when you go state to state, community to community, there are very different needs. And that's something that an across-scale private sector company just is not able to accomplish. But where I have seen that be successful is with the HIE, health data utility approach that you brought up. So I would love to hear, actually from Denise, being one of those markets, how has that governance structure specifically for the district benefited you? More jokes might be coming, y'all. I don't know.
Oh no. Oh no. Is it? Can you all hear me? Is this? Can I get a thumbs up? We're good. Okay. I think it's this model has been just tremendously impactful. But CRISP DC and its partnership with DHCF really goes back before the shared services model. And I mean, if we go back a few years to 2017, 2018, the district was really in the same space that the Virgin Islands is today. We were just really starting out. CRISP had a major presence in Maryland as our next door neighbor. And we were really just getting started and trying to figure things out. We did a lot of stakeholder engagement initially with our community to really understand what the needs of our specific health system were. We didn't want to make any assumptions. And again, all of this culminated in a strategic plan that we released in 2018, which has been our guide that laid out opportunities to improve healthcare, kind of specific issues that have been experienced in the district. We have high maternal health mortality, kind of challenges with behavioral health care, challenges around transitions of care. And there were a lot of these priority areas that we saw that we could help alleviate through the implementation of effective digital health tools. So it's really through this plan that we laid out several priority areas to focus on over a period of 5 years. So how do we use health information exchange infrastructure? How do we get folks connected to it to support transitions of care? To support population health management through analytics. So not just about connecting EHRs or provider organizations to the health information exchange itself, but also enhancing it through tools that are available at the point of care through a single point of entry. We kind of focused on not just connecting people, but really ensuring that over the course of time, we see sort of a sophistication of use. And I think this model really, today we can kind of look back and say, you know, there are over 1,000 participating organizations in the district that are connected to the Health Information Exchange. That means all acute care hospitals, 36 long-term care facilities, including our nursing facilities, home health providers, all of our federally qualified health centers, behavioral health providers, and even in the last couple of years, we've entered this foray into community-based organizations. So really bringing together health and social service providers, which is really innovative work around the country. So really exciting stuff. And I think what's particularly wonderful about this new shared services model is that if we develop a technology within the DCHIE, that can then be reused by other states who are part of the CHRIS shared services. So something we develop can be used in Alaska, or something that is developed in Maryland can be used in West Virginia and by us. So I think it is really, it's a sustainable model, it's an effective model, and it's just a smart model.
Denise, I was the executive director of CHRIS DC for 4 or 5 years, working with Denise's team. And I think the cool thing about DC, which I think is similar to here, is the compact geography allows you to innovate in the entire system and push out innovative things that maybe you couldn't do in a very spread out location with lots of different types of organizations. And so when I look here at our opportunity to do some cool things as a demonstration for the country about how you might improve healthcare, it really is a great place to try those things and to lead, because you can demonstrate the whole continuum of care and how like a social determinants of health program like we did in DC, or an absenteeism program, or a lead screening program can impact everybody, and then go to the federal government and say, you invested partly in this, you know, this is what we were able to do, let's spread it out. And I think that is the real value of this location specifically, is the ability to really do some innovative pilots and track them.
Something that I thought was really interesting, and talking about getting this information to the point of care to make a difference. That's, I mean, I want to hear your thoughts on that, because this is more than just connecting data and flinging ADTs around and CCDs and whatever, right? This is about impacting communities in a positive way. So I'd love if both of you could take turns talking about how you're able to do that with your model.
We didn't hear who you were directing it at, but maybe I'll start and then.
Ryan and Doug. Oh yeah, you all y'all.
So maybe because I also skipped Kat's first question about the LOI and what we actually intend to support here, maybe I'll also hit that to be a little more clear. So when we talk about this model, we talk about, as Denise said, this reusable infrastructure. There are certain components that, and acronyms that I'll ask Ryan to get into, that are either useful and necessary for solving the problems or implementing use cases that Mark can tell us about. But these things are very flexible and very scalable, and in many ways they're also somewhat innovative. And so you'll hear about things like US CDI, you heard about yesterday. Very, very few people, if anyone, has implemented that core data standard at any kind of scale across any kind of environment. And what Michelle asked is, well, to Ryan's point, in a somewhat small, aligned group who wants to do really impactful things for their population and their patients, could we try and do those things? Could we prove that that core data standard, and that these new public health use cases and that FHIR APIs are useful, effective ways to support maternal health and other really important outcomes. And for us, we would love to prove that the things we've been developing are cutting edge, are leading the country, are helping to support the longer term technology strategy. But none of it makes any sense to do if it doesn't help individuals. And so we need partners who help individuals. And that's where certainly DC and West Virginia and hopefully you all come in.
Yeah, maybe I can share one or two use cases that I think are particularly impactful, just to give you some ideas of how we've been able to use this great technology to actually impact patients and improve population outcomes. So I'm a pediatrician. I still see patients that are hospitalized. I frequently see patients that are admitted for asthma exacerbations. And I often see them visiting 1, 2, 3 times in a year. We are very good at treating their asthma when they're in the hospital and being able to send them home. We give them the refills on medications. We teach the patient and their families how to administer medications. But they still come back 3, 4, 5 months later. And it's particularly frustrating to see that happen and to feel my hands are tied to be able to prevent that from happening. I had one patient a year ago who, it was her 3rd visit in a year. We found out later that her lives in low-income housing. Her landlord was not keeping up with maintenance in the facility. There was mold in a lot of the house, in addition to vermin that were triggering this child's asthma. What can I do for that as a pediatrician? And so that's an example of this patient multiplied by hundreds and thousands of patients across the country, having poor outcomes because we can't work upstream and really get to the root cause of their disease. And so in Maryland, there was an initiative, there was an initiative to decrease emergency department utilization for children with asthma. And so through Maryland Medicaid, in partnership with the health department, implement home visiting programs that can go into the home, mitigate mold, get rid of vermin, do in-home education on how to administer medications. But they were having a very hard time identifying their patients that were eligible for this program. And so we were able to basically listen out through those ADT feeds that Craig mentioned for patients that were visiting the emergency department more than once or admitted, so had poorly controlled asthma, and then in real time, send that patient information to the health department, who then could call the family and get them enrolled in home visiting services. And the health department really found much higher ability to reach these families and get them enrolled in services because they just had a crisis, and they knew that removing some of the triggers from the home was a really big priority. And so we really saw how this technology can impact the patient and get to some of these root causes of poor control of disease and really prevent poor outcomes. On top of that, we're able to use some of those same data feeds to look at trends over time to be able to see what the rates of ED utilization for children with asthma is over time in the state. And so now we can see how are these interventions really impacting patients at the population level. And so that's just one example. I'm happy to provide more of how this technology can really impact patients. That's why I'm here. That's why I find this work so rewarding, to really find those use cases that work for your populations and that are really high priority.
And I'll just reiterate that technology-wise, it's actually relatively simple to get these types of things started. Those ADT feeds are standardized feeds that hospitals have been using for years, that health systems have been using for years. It's not technically complicated to get started on that. And you can sort of very quickly, with the data Craig mentioned, make these kinds of impacts just through some basic, simple connectivity. And so I think, we're pretty excited to get started as fast as we can to show that as part of this pilot.
Awesome. Thank you. Thank you all. Craig, would you like to talk a little bit more about some of the elements of the pilot that will be early stage collaborations?
Sure. And so maybe I'll do this, picking up on Mark's theme, and then we should talk about policy and governance and sustainability and all the things that, quite frankly, are harder and matter as much or more than technology. So everything Mark talked about, getting real-time hospital feeds, getting Medicaid beneficiary rosters if they're available, getting certain public health data, whatever data is available and appropriate can come into our master person index, which matches people, and live in a secure data lake, and then be presented through tools, whether it's secure file transfer or a patient lookup tool or push notifications. But you could replace children with one or more ED visits for a diagnosis of asthma with women who become pregnant but don't have a primary care physician, or some other high-risk condition. I won't even pretend to make up a high-risk condition, but kind of it's the same pipes. It's just a question of what is the population that's meaningful and that you are intending to impact, and that you have broad stakeholder support to try and make a difference on.
Maybe I can share one opportunity. I think when we think about maternal health outcomes, wouldn't it be great if the FQHCs knew that their patients went to the emergency department after delivering? Wouldn't it be great to be able to identify those very high-risk populations to decrease morbidity and mortality in that population, to be able to really have an impact? And that uses the same technology, the same ADT feeds, to be able to identify those populations, and it's scalable across different use cases.
So the pilot would be, again, working with Michelle and, of course, public health and Medicaid and everybody who's willing and already coming to the table, because I know you've had some pretty thoughtful discussions around health information exchange already, to say what is the population we intend to impact. I think maternal health makes a lot of sense for a lot of reasons, but it's really up to you all. And then what is the data necessary to run that implementation, to run that program or the pilot, and then did the pilot work? And if so, what's the next incremental step? And if not, is that our fault? Which I hope not, but if it is, then we should not be doing this work. And if it is another cause, how can we mitigate that cause? But I think it's, again, really important to focus on the idea that a pilot to prove that FHIR APIs and US CDI Plus can be in the workflows of clinicians to support maternal health is technically very doable, and we're excited to do that work. But the much harder work is figuring out what is the appropriate way to drive patient consent. This is very likely an opt-out model, because most patients want their data to flow through their provider communities to make sure that they can receive adequate and whole person care. But if you don't want that, you should be able to opt out and not have your data flow, which means we need to tell patients that and then honor their preferences when they give them to us. We want to make sure that it's up to you all to determine what are the appropriate use cases, who should that data flow to, who shouldn't that data flow to. We very much can implement technology to solve problems. We are not the ones who can identify the problems or tell you how to solve them. That is not our role. So I'm really optimistic that we can show some small but meaningful progress that hopefully gets people excited to then reuse these tools to maybe use some lessons learned from West Virginia, or maybe bring some lessons learned here back to West Virginia, and really kind of build this utility out, certainly slowly, but over time it'll be a really meaningful impact.
And Ryan, my camera's right on you, and it looks like you have something to say about that.
No, not really. I mean, it's
not really.
the governance structures, and we've been talking to Michael and the PCG folks, and there's a great foundation already being laid for getting the right people to the table to decide what those permitted purposes will be, what data will be exchanged, how it will be exchanged. I think it's important to know in the technology stack, the data that goes through it, the provenance is all kept, the data remains under the participants' ownership and control. It can be removed at any time. It's not data that we're looking to do other things with, except specifically what these governance folks here in the Virgin Islands say to do with it, which is, I think, part of the reason our model works is that the local governance really dictates what happens to the data, what happens, in a world where there are a lot of technology vendors who are trying to figure out ways to monetize data, having a nonprofit that can work with governance in a local jurisdiction to really understand with transparency where the data is going and how it's used is important. And our technology stack is open to that. We're happy to talk to CIOs and CTOs and explain exactly where the data is going, what we keep, how long we keep it for, what we use it for. And then the consent process is pretty robust in that if a patient doesn't want to participate, it all gets deleted. It's a very advanced model. I wish our CISO could be here, Bezowit. She's awesome. She's one of the industry leaders. She's way bigger than us, to be honest. She's on national stages with big IT companies talking about ways to keep the data private and secure. So I would just say that governance and the privacy security work hand in hand to make sure that we're delivering the right data to the right person at the right time.
I mean, maybe to that point, I also want to make sure when we think about the utility, we are a very maybe small foundational portion of a health IT ecosystem. We do not want to be and cannot be everything to everybody. And so, as Kat mentioned, kind of for-profit vendors or other people in the space, I think really what the utility, what we intend to do is make all the data available to everyone who's allowed to have it. No more and no less. And so if you have robust analytic tools, or if you have some additional care management infrastructure, or if you have a homelessness information system, the data, if you want it to, the data should flow through us at no extra cost to any of these additional tools to do more things with it. You want to do robust analytics and machine learning and artificial, great. Go do that if that's what your governance groups and kind of stakeholders want to do, and we'll make the data available. We're just trying to make sure that the data can flow freely and efficiently to whatever purposes make sense.
Wonderful. And if someone could let us know of how much time we have left. I have two big questions, and I know we're a little over schedule, starting late. And if we don't have time, I'll ask in order of priority. But Craig, you've talked about governance. You've talked about this collaborative approach. Ryan has mentioned it as well. I'm curious to know, just in general, how CRISP Shared Services does approach working with other markets. My experience has been it's extremely collaborative. It's almost like affiliates are the coalition of the willing, right? Those that are interested in furthering interoperability for the greater good, sharing technology, sharing ideas. But your approach has been, especially in our experience working in Alaska together, very big feelings, a lot of different community needs, and your team has come in, been very calm, cool, and collected, and really facilitated some incredible progress forward. So I'd love to hear and have the audience hear how you approach collaboration and how you approach that unique model.
Yeah, I mean, very selfishly, this does not work unless people in the community, both the providers and the policymakers, want it to work. And it does not do us any good to force any kind of model onto anybody. And so what we've done in a place like Alaska, for example, they had a nonprofit health information exchange kind of organization. They had governance in place, although some leadership challenges meant that the Hospital Association and the Alaska Native Tribal Council both dropped out of that governance, which was a pretty major part of Alaska. And they said they wanted technology that they didn't have to worry about, right? They wanted the service levels, they wanted the privacy, they wanted the security, they wanted the tools to make sense, so that they could then try and win back some of these different groups. And that's great. That's exactly what we want to do. We want to let the local people focus on provider relations and funding sustainability and innovation. And the nice thing is, and it does make our job much easier, when the technology works, then you can go out to communities and have creative conversations and promise things. And then when skeptical audiences, because they should be skeptical, have good experiences with technology, solving actual problems, then they want to be at the table, and then they want to invite their friends to the table, and then we want to do more with technology. But again, none of us kind of being in a market or having data does no good to anybody unless the data is being used at the point of care and through public health and with Medicaid to actually impact your population for the better. And so it really is, you know, we're happy to tell you about our scars and our lessons learned and what we think works and doesn't work. But everywhere is different, and we need you all to be excited, and I think you are, and I think you're moving forward in a really positive direction, and we're really happy to be involved.
It's wonderful. And if we have time, one example that I'd love to hear about and potentially to close out this session is there's been a lot of talk about maternal health. Denise, I know you all have a pretty incredible program going on in the district. And Mark, I know that's something when I first met you that you were very involved with. So Denise, I'm wondering if you can kick off talking about how CRISP helped you start kicking off that program collaboratively as an example of how it could work in the territory. I know, like we said, everywhere is different and communities are different. And then Dr. Rabner may be talking about how you made that come to life.
Sure. So I think one of these, I want to go back just a moment in order to answer your question, Kat. I want to go back just a moment and talk a little bit about and how we approach, you know, as a government entity, how we approach our partnership with the HIE. From our perspective, the DC HIE space is really this like regulated public-private partnership. And, you know, it has this foundation in community governance and regional partnerships. And we want to ensure that we're always being responsive to the needs of our health system. And I think what's so great about kind of our direct partnership with the CRISP DC affiliate is I think we have kind of this approach where we don't build technology for the sake of building technology, right? It's about what is the problem that folks in the health system are trying to solve to deliver better care. And I think maternal health is a really great example of this. Right. We unfortunately have some of the worst maternal health outcomes in the District of Columbia and out of the entire country and compared to a lot of developing nations around the world. So I think just getting through our collaborations, we're able to get very specific about the issues that we're trying to solve and working with the community to understand what their needs are, what are the gaps in information, and trying to meet them there. A couple of things that have been implemented are kind of repurposed, which are great innovations that have come out of the CRISP DC team. There's a patient care snapshot tool, which is essentially like imagine Facebook within the health information exchange, where you're able to look up your patient at the point of care, and it displays kind of how they've touched the health system, any medications they're on, kind of anything you need to know in order to make quick clinical decisions. So really effective in an emergency department space. The CRISP DC team came up with a maternal health filter that focuses just on maternal health utilization to allow providers to identify gaps, identify kind of who, if folks aren't regularly in care, do they need to be brought in. We've recently started exploring looking at this from more of a panel level, so not just a kind of single patient lookup capability, but starting to use the analytics that are founded on kind of the robust data that is flowing into the health information exchange. So really looking at how do we leverage the Medicaid claims data that is flowing into the HIE, clinical information that is flowing into the HIE, to support analytical tools to allow providers to not just look up individually, but for their entire patient panel, be able to compare to the general population, but also be able to identify, who should be coming in for a follow-up visit after delivery for postpartum care, who hasn't been coming in for regular checkups. So really be able to monitor their population more closely with reliable tools and reliable data.
Sign, but also a chance for questions if there are any locally. We can help you moderate audience questions if there are some. I think a microphone's coming around.
Thank you. My question is, so I'm a physician and a patient, so two things. The opt-in, the opt-out option for consenting for my information to transfer, I mean, I'm not a big fan of that type of policy, one as a patient and as a provider. I mean, real world incidences, I have a patient last week, I go in through my EMR to see her, and I can click and I can see everything that every hospital she's been into in the States, well, not everyone, but the ones that are linked with my EMR, and I can go in and I can browse through her chart. Now, if that same patient goes to the hospital today and goes and gets admitted, I can't legally go into her chart and look in her chart. It's a HIPAA violation. If I'm in the hospital and a patient's in the room 54 and I go in and say, let me just go look at her chart, see what's going on, that's a violation. But right now I can go and look at everything in the country about this patient that's sitting in front of me. So that's something somebody has to solve. And having patients opt out, that's not fair to people. That's not fair to most humans, the way they encounter naturally with other people. That's a big thing. And then the second thing is, whenever we have these innovations, and I know you guys are, like you said, you're building tools for us, and we appreciate that. And that it's for us to then give you the feedback on what we're seeing. When we're looking for consenting our patients and getting this data, we have to respond back to you. So as a provider, it's not for us just to have a complaint about it, but to have a vehicle set up in our community where we can say, okay, I see a problem. I foresee a problem with this encounter. Can I ask a question about it? How do we solve it? How do I get this up to my IT guys to be able to solve? So I think from a community standpoint, from physicians, we also we're going to have to get on board with this. This is something that's going to happen in the future, and we need to create vehicles to get conduits to be able to get that information back to you when we see problems.
Yeah, so I'll start with the second point, because I entirely agree that the core of health information exchange is helping clinicians interact more productively with their patients, but adding one more alert or one more IT feed or one more headache does not help anybody in any sense. And so something that we've done, and certainly Denise can comment on either of these, in kind of all the jurisdictions, is look to local physician leadership, local groups, to say, what data, what gaps do you currently have, and how can this infrastructure help fill those gaps? And it's a little bit different for different folks. Care managers looking for different things than a physician would be. But I do think, our intention is to be very configurable and very flexible and very mindful of what problems do the end users need to solve and how can we productively solve those problems. But there's a lot more to get into there.
Can I add on?
Yeah.
I think your analogy yesterday about where the rubber meets the road is very apropos. I mean, it's we've worked very closely with physician partners across our other affiliates, and they help bring those use cases and those problems to us to help solve as a community together. And I think that's just as vital. It's going to be just as vital here as anywhere.
So then in terms of opt-out, and I'm going to try not to kind of get in the kind of HIPAA history and world of opt-out, but so our experience has been most patients expect their healthcare teams to have their information conveniently. When you leave the hospital, kind of our expectation, kind of as a patient, is my primary care doctor knows what happened in the hospital. And there are a lot of kind of meaningful systems that have made that happen, both kind of health information exchange, but also EHR networks, and now the Trusted Exchange framework at the federal level. So there's kind of a lot of things flowing through. We found that kind of in terms of the HIPAA legal policy, right, anything that would be illegal or not allowed via HIPAA is still illegal and not allowed. And so, as we think through, someone could go into a medical records room and kind of flip through charts, just like they could go through an EHR and flip through charts, just like they could search in CRISP and flip through charts. And all of it's not allowed, to your point. That said, when you can flip through charts more easily, we got to be really thoughtful about the audit, protection, and control, and kind of level of trust. And so on our side, from the technology level, we solve that obviously through monitoring who's searching for who. So if, for example, we don't see that the individual has a relationship with the patient because they've never had a visit there, they're not on a patient roster, we create kind of pop-up alerts that say, by proceeding, you're acknowledging that we don't know about a relationship, and then we audit all of those. We have monitoring solutions, so if you look up Tom Brady, right, it stops you from looking up Tom Brady because it's very unlikely that most of us have normal healthcare reasons to do that. But I do think the last kind of point about opt-out is probably the most critical one from an implementation standpoint. And what I mean is, I think most states, DC, West Virginia, Maryland, have created opt-out as kind of a way for people who want none of this to happen to stop it from happening, because we need that to be an option. Very few people know about it, right? Because you put your HIPAA authorization forms that we all sign when we go to the hospital or the doctor, and it's 14 pages, and the last page you sign and you say, yeah, I consent to treat. And so I think as an industry, we need to get much better at explaining to patients what your data is being used for, who it's going to, what rights you have. One of the nice, I'm an optimist, one of the nice things about kind of starting later in the HIE landscape is that we have an opt-out model, and that's fine. We're actually looking more at broader consent models because, yeah, we need to opt out if you don't want your data shared, but I'd really like for you to opt in if you have substance use disorder treatment data, because that's part of your whole person record, and that should be part of your treatment if you as an individual want it to be. Or I would love for individuals to opt in. They would do HIPAA authorization to consent their data being shared with community-based organizations that have dietary food programs, and then maybe have relevance to understanding your diabetes progression. So I think we're getting better at understanding how to honor preferences. It's not great, and part of that is also the locals telling us, or telling each other, how should we notify patients, what's the right communication process, how do we create informed decisions.
Yeah. These happen to me every day. So we have foxes in the hen house to a certain degree because we're building all these things, this access to information. So there are a number of companies that help you bill for certain things, like fall prevention. So you have these fall prevention programs. They'll come to your office and say, hey, we can help you with fall prevention. We'll implement it, and we'll give you the software that goes along with it. And by the way, the data is ours. It's not yours. It's not the patient's. We control it. We're going to sell it. We're going to manipulate it. It is ours. That's why we're coming in. And then when you push back and say, no, listen, the data belongs to the practice and it belongs to the patient. Well, we can't help you. So, but if I never asked that question and I had implemented that process in my office, now I'm leaking all this data out to the world that is being exploited for economic gain. So that's just my input.
Yeah, no, I mean, we agree. Like, the data is not ours. Our model is that, and this is why it's a letter of intent and not more binding than that, is that data protections, ownership rights, everything lives where it still is. We only do with the data what you tell us to. But you're exactly right that there's a very broad ecosystem of not great data use, and so you're right to think about it. Yeah.
Here we go. I'm going to just ask you guys to give your names and your titles again, because I think we didn't go around, or I missed it, but I wanted to make sure everyone knew, at least Craig, your team that's here.
So I'm Craig Bem. I'm the CEO of CRISP Shared Services. I actually was the executive director of CRISP in Maryland for 5 or 6 years. Been with CRISP for over 8 years at this point. And like I said, I'm just really excited about what we're trying to do, kind of both here and just in general, right? Because the idea of a utility, you have an electrical system. We're not telling you what you do with the electricity. We're not telling you how to run your AC or to turn your lights off. But kind of once you have the electric grid in place, really smart people can do really good things with it. And so thanks for having us.
And I'm Ryan Bramble. I'm the Chief Operating Officer for CRISP Shared Services. I was one of the first members of the CRISP team back in 2008, getting things off the ground. Came up through the IT side, was in charge of IT for a while, and as I said before, Executive Director of CRISP DC when that formed back in 2017. And now my job is to basically oversee IT, HR, support, our data team, all the different teams that make up operational impact. And it is members on my team who work with our affiliates and have relationships with the individuals inside each state territory that we're going to be working with, and really help them navigate the process of sort of the complicated nature of a health information exchange, and looking forward to working with you all as well.
And I'm Mark Grabner, I'm Chief Medical Officer, CRISP Shared Services. Most recently, so about 3 months now. Previously, I was a clinical advisor to CRISP for the last 4 years. And I really, part of my job is making sure that the tools that we have provide value to all the stakeholders, to patients, to providers, and make sure that what we build actually helps people.
Thank you. I think we lost Denise, but we were hosted by the DC team, and that's where for our governor the lights really came on, as they were sharing some of their use cases and how the CRISP Shared Services technology helped to really layer SDOH data with the clinical data to solve real problems. So I want to say thank you to Denise and that whole team for hosting us. And you said something, Craig, that I think is true. It's where we are today. We need to make small but meaningful progress, because we can talk about this for another 13 years and not all agree. We can argue opt-in, opt-out models and not make any progress, but making small steps. I think a pilot is a fantastic way for us to be able to push back, for us to be able to kind of get in the sandbox and play around and say, does this work? Maybe we don't like sand at all. Maybe we will just stick to what we've always been doing. But I think what we will discover is what we'll clarify more what the tools can help us do. And then we can, as a community, decide with Department of Health, with the Medicaid department, with our hospitals, our FQHCs, our providers, what are we trying to solve, as one of you stated. So thank you very much. Kat, thank you so much for joining us this morning and facilitating this conversation. We may ask you to, well, I will ask you to just put something together for us that we can put online about Chris Shared Services, so that when folks go back to refer to it. And then Kat, if there's anything you want to share, like a little one-pager, we'll put that up as well. Thank you all so much.
Thanks so much.
So one of the questions, and a very relevant question, is, okay, we talk about telehealth modules, we talk about implementing and upgrading our current systems, whatever those systems are. We talk about RPM, and we need it all, we want it all, but it all comes with a price tag. Then there's lots of funding. So we'll say, there's funding for that, there's funding for this, there's funding. But that funding comes with a need to report how you've spent that funding. It comes with guidelines. Then there's the question of, we do have funding, what funding do we have? Who has that funding? Who's it available to? So this next panel, I think, is going to be really engaging and informative to answer those questions. So funding and cost transformation. So as we're talking about all the work that we need to do, what do we need to know about how we fund it, how we track it, how we report it? How should we be thinking to use these tools to actually generate revenue and to reduce cost as well? So I'd like to welcome to the stage Karen, if you guys want to go ahead and come up. Karen Shields, who you guys met yesterday, Adam Lukring, and Pravinth Namber. Also Alex Smith Francis. I'm looking over at them and I was like, someone's missing. And I think you were trying to intentionally be missing, but we gotcha. Okay, do you want to grab this? Do we need another handheld? Can we get one more? So again, after they're done, there may be. I'm looking at your socks. We may be looking at socks after this. So that's the warning.
Mine are very boring.
Okay, so we know who's not winning the sock competition today. All right, thank you guys. I'm going to ask you to just start by introducing, just a brief introduction, and then Adam's going to kick us off. And then I believe we're moving to Pravinth, and then to Karen and Alex. Thank you.
Good morning, everybody. Adam Lukring, CEO of Clear Impact. We're a small company based outside Washington, D.C. We help government and nonprofits use data for decision-making and planning. We've got 2 software products that help support that. But what we're here to do today is to talk about funding and cost transformation. I'm going to share a little bit about my background, my new book, which is called Social Sector Hero: How Government and Philanthropy Can Fund for Impact. But I have the honor and privilege of also moderating this esteemed panel as well with Pravinth, Karen, and Alexandra. I'll let you guys quickly introduce yourselves.
Good morning, everyone. Good morning. Alexandra Francis Smith. I'm the Federal Project Manager for VI-NGN, and just want to talk about some of the grants that are available to the U.S. VI territory and how it supports this effort.
Good morning, everybody. Hi, everybody. I am Pravit Nambiar, Director, Senior Partner with Chartis. And for those of you who do not know Chartis, so we are a national advisory firm. We work with payers and providers to help them navigate, to manage the future of healthcare needs. In terms of my background, I work with our payer and provider community in helping them build models that are financially sustainable, whether working with the states to help them transition from fee-for-service to managed care model, or providers moving from fee-for-service to take more value-based care risk, whether primary care side or ACO or a full capitated model, work with the providers, and also help them understand what are the different capabilities from network, clinical, and financial standpoint that they could deploy so that they can be successful. For the last 4 or 5 years, as part of the evolution of financial transformation, I've been working on SDOH and health equity, specifically with community providers in terms of building models for housing, food, transportation, and again, helping them scale the model across and outside their communities. Thank you for having us today.
Good morning, everyone. My name is Karen Shields, and I am currently the Chief Client Engagement Officer for Gainwell Technologies, and Gainwell has a large footprint in the Medicaid payer space. We manage Medicaid claims for over 30 states and are also one of the largest third-party liability payers in the Medicaid space. But for this particular conversation, I would like to bring about some lessons learned from my leadership epic fails in budgeting and financial preparedness and planning, and my experience in the federal government, and two roles that will be pertinent to this conversation, which is as the senior career official responsible for all contracting and oversight for ACA implementation. That goes to that epic fail category for the first part, and for Medicaid and CHIP. So both as a person responsible for asking for federal dollars and dispersing billions of federal dollars, even when it's $27, the same concepts in my experience apply. So happy to be on the panel.
Well, I can tell you, epic fails lead to great learnings. So
absolutely.
Glad to have you
Actually,
here.
they probably are the preceder for them. Like, you can't have them without it, so yeah.
100%. All right, so if it's possible, I'd love for my slides to come up. My slides, we'll do Alexandra, and then we'll do Prevent, and then we'll get into a conversation moving forward. So if I could pull that up. So in my book, Social Sector Hero, How Government and Philanthropy Can Fund for Impact, the goal here is to actually share 8 core strategies that I think are very important from what I've learned over the last 20 years helping government and nonprofits do better performance reporting. Next slide, please. Here's our team, Clear Impact. We're all over the country. Great team that's actually at a conference in Baltimore a couple of years ago. Next slide, please. Here's a sampling of our customer base. What's most important here, we work with foundations, nonprofits, governments at all levels. What's most important here is we work with 17 different state health departments, particularly to support state health improvement plans, community health assessments, and also FAB accreditation. Hopefully we will help support you here as well. Next slide, please. Now, when we talk about a social sector hero, generally speaking, you might think, okay, so, Superman, Batman, Black Adam, whoever it might be. But at the end of the day, anyone in this room can be a social sector hero. The difference between someone who is a social sector hero and who is not is the commitment to make a measurable improvement on something in your community. Now, I repeat, a measurable improvement on something in your community. And in doing so, that leader, you as a leader, can have anxiety, you can have interpersonal issues with someone down the hallway from yourself, with your partners across the street, etc. But at the end of the day, it's that commitment to a measurable improvement to something in your community. Next slide, please. Now, here are the 8 performance reporting tips for funders. Number 1, we want to align with a common purpose. I'll tell you what I mean by a common purpose shortly. Assure alignment with your partners. You want to remember that less is more. Disaggregate your data by race and gender. We want to be consistent and flexible. Never report the data without the story. Use the data and corresponding analysis for meaningful dialogue. And ultimately, share your performance reports publicly. Next slide, please. Now, when I talk about aligning with a common purpose equals a result plus an indicator. For me, a result means a condition of well-being for children, families, or communities, and then an indicator is a way of measuring that. And so it ultimately is that North Star that everyone's working towards together. So for this audience here, we're talking digital health conference. A result might be all people are healthy. And a way of measuring that obviously could be the mortality rate, morbidity rate, could be cancer rate, could be the percentage of babies born healthy. Whatever it is, you're saying this is our North Star. We are, as a community and with all partners, working together to make this happen. And I think ultimately, this is probably the most important of the 8 tips. If you can't get this right, most likely you're not going to get the rest of them right. Next slide, please. The second is to assure alignment with your partners. And one way that it's really about creating a culture for which you're using data. And ultimately, one tip for that is to have what I call a 1-by-1-by-1-by-1 meeting or a 4-by-1 meeting with each partner every year. And so that's one metric for 1 hour, one partner at a time, at least once a year. And the idea here is you're having an actual conversation or dialogue using data at least once a year. Next slide, please. Now, less is more. If you're measuring everything, you're measuring nothing. I think everyone in this room knows that. And so we offer 3 types of creating performance measures as part of our process for helping organizations better manage performance. First type of performance measure is how much did you do? That might be the number of partners you have or number of people served. The second type of performance measure is how well did you do it? That might be an efficiency measure, such as the percentage of attendance rate or the percentage of your staff with an advanced degree. But lastly, and most importantly, and ultimately the reason why you get up every morning is you want to know whether or not someone is better off. And those are the changes in attitudes, behaviors, skills, knowledge, or circumstance. And by looking at all 3 of those types of performance measures, I would offer that you want to pick no more than 3 to 5 of those that you measure and manage performance and report to your funders with. Next slide, please. The next tip is to disaggregate your data by race and gender. This is actually an interesting slide because it's the unemployment rate for the people of the city of Akron, Ohio. And they thought they were having a huge success. They went from 8% to 4% unemployment over, I think, a 10-year period. But if you actually disaggregate the data, you look at black and brown people in that community, actually the disparity increased by double in that same period of time. And if they had not looked at disaggregated data, what they would not have found is conditions actually getting worse for people within that community. Next slide, please. Now, this tip's interesting for a funder, right? So you want to be consistent and flexible. And the best way I can explain this is actually to give you a photo of my 4 kids. That's Connor, he's 14. My son William, he's 11. My son Peyton, he's 9. My daughter Caitlin, she's 7. And ultimately, I want consistency for all 4. I want them to be happy, healthy, and thriving, right? And I think everybody in this room wants their kids to be happy, healthy, and thriving. But what's different and interesting for each is that they have different interests and areas for personal growth. My daughter is extremely shy. We need to work on her coming out of her shell a little bit. My son, William, he talks a little bit too much. We got to rein that back in. But what the analogy here to grantees, let's assume you are funding like programs in your community. You want to set consistent measures across all of them. But you also want to give them flexibility to report on what's unique to them, because every grantee, every program that you fund is slightly different, and you want to acknowledge that. Next slide, please. Number 6, never report the data without the story. Now, what's interesting here is that if you report data and just data by itself, there's no context. We don't even understand what it means. So we say is never report the data without the story, and therefore have, in doing so, you have transparency not only of the data itself, but of your analysis and plan for improvement. And laying that out for people to join you in your thinking is very important. Next slide, please. Tip number 7 is to support effective dialogue. And in doing so, what we really are trying to accomplish here is to have effective questions, or a way to talk to each other. So for example, in looking at the data, what are the most important factors influencing performance? Who are internal and external partners that can help you? What would work to improve it? And ultimately, what do we propose to do between now and the next performance reporting period? And this allows for greater dialogue, joint thinking, joint understanding, etc. And then lastly, tip number 8 is to report your data publicly. And so in doing so, I'm sharing with you, this is SisterWeb. It's a small community-based doula network in San Francisco, budget under $2 million. And if they can report their data publicly on their public website, they've got a section on their website called Our Impact. They've got 4 different scorecards on their webpage related to their performance. I would offer that anyone in this room can do the same. And what that does is ultimately create the ability for partners, donors, et cetera, to attract more funding because they have trust in what you're offering. And so those are the 8 performance reporting tips. My book, Social Sector Hero, can be, next slide, can be found downloaded for free on our website, socialsectorhero.com. Within the book itself, there's the 8 strategies, but in that we also have 2 case studies of organizations that are actually living it and what they've learned and what they've accomplished. But with that, I want to say thank you, and I'm going to turn it over to Alexandra.
Thank you. So I also have a PowerPoint, very brief, and just want to talk about how the grants that have been afforded to the USVI supports the efforts that the OHIT team and all of the experts present. So VI-NGN initially, my presentation, thank you. So VI-NGN initially after COVID were awarded from the Department of Interior a grant which allowed us to install Wi-Fi to our communities and places people gather, 65 Wi-Fi locations, because we realized there was an effort where folks didn't have access to internet and that was the only way to communicate. Children didn't have internet at home, and this was a direct effect. So in addition to that, next screen, we were awarded the ARPA Community Wi-Fi Project Grant. And I'm going to talk about the Affordable Connectivity Program, which is available through ISPs. And finally, the Digital Equity. So with the ARPA Community Wi-Fi Project, VI-NGN was awarded additional funding to provide 95 additional hotspot locations in places people gather in housing communities, which will allow for distance learning, telemedicine, virtual government, which Governor Bryan spoke about how much time was saved by just registering your car. That's part of your virtual government. And of course, internet access and affordability of broadband connectivity. So when we talk about modernizing healthcare, it's kind of limited if your folks don't have access to access the internet and do their medical screening, access your lab results, and so forth. Next screen. And we also have the Affordable Connectivity Program, which is funded through the FCC. And eligible applicants receive $30 a month towards their internet bill, and that's through their independent ISPs. And it also allows for $100 one-time discount for the purchase of a device, whether it be a cell phone, a tablet, and whether their choices are. And these typically are recipients of SNAP, Medicaid, and other government subsidy programs. And it allows for scheduling of medical appointments. It allows them to participate in virtual doctor visits, and of course tracking their vitals, so then it's easier for them to upload information to their physician, and of course communicate with their healthcare providers. Next screen. And finally, we have the Digital Equity Grant Program, which is through the Biden-Harris grants. It's a multitude of grants, and it's Internet for All, basically bridging the digital divide. And what's that? That's talking about equity and equality, where everyone has free and reliable Wi-Fi access, Internet access, and providing for the Virgin Islands to upgrade their infrastructure, and directly via NGN to upgrade our infrastructure to support these efforts for example, equipment, providing computers to folks, providing high-speed internet, computer classes. So it's an opportunity for communities, if you already have a program going on, to apply for these grants through the digital equity. And that is through the NTIA, and we just want to thank the Office of the Governor and Office of Management Budget for their support. Additionally, there are additional grants that we're not awarded at this time that will directly affect Office of Health IT, and it is through the Department of Treasury. It's called a Capital Project Fund, and this will of course support the medical platforms that we are currently working on with all the providers here. And I thank you so much for your time. I'm Alexandra of VINGN. If you have any further questions, I'll be more than happy to take them. Thank you.
Ravinth?
Okay. I can get Charter's presentation up. Okay, next slide, please. Again, as I said, like Chartis, we are a national payer advisory firm, work with payer and providers to help them navigate future of healthcare. Next slide, please. Here are some of the clients and partners that we work across payers, states, providers, health systems, and other technology vendors. Next slide, please. Next slide. Okay, so just to pull the conversation a little at a macro level, before we get into funding and financial transformation, just want to highlight a couple of key stats here. One, CMS just published their actuarial, what they call national healthcare expenditure data a couple of days ago, which is expected to, or projected where the healthcare cost is going to become 7.1 trillion by 2031. And currently, 2022-2023, the same cost is 4.6 trillion. And what this means is that, why I'm stating these facts is that when you look at these numbers, there are two key aspects within the data. One is where as the healthcare grows from 2023 to 2030, 23 million new members or patients will be enrolled in government program. And this includes Medicare, fee-for-service. This includes Medicare Advantage, DSNP, PACE programs, Medicaid, which includes both the fee-for-service MCO model, and also ACA and other government programs. And then the second part of the data, when you see the data, you would see that commercial market is somewhat going to be flat for next 7 to 8 years. And in some states, the commercial market is going to decline, and because of the aging population. And these two data, the macro impact from an economic perspective is that as the government-funded program grows from the current 1.3 trillion to 2.9 trillion by 2031, that's going to add a lot of cost pressure on the government, whether it's on the state side, federal side, the local community. And when there is a cost pressure on the government side, that's going to trickle down specifically on the provider community, who have a greater mix of serving Medicaid population, Medicaid members, and who manage their finances primarily through government funding. So with that said, for the next 3 to 5 minutes, plan to focus on what are the different strategies that providers and community stakeholders in Virgin Island could partner with Virgin Island Medicaid and other government stakeholders in order to develop innovative models to build a financially sustainable care programs. So as part of, as you may all know, the Virgin Island, in terms of their Medicaid, roughly 37,000. But again, that's going to come down if redetermination of the members are going to lose coverage. And then there is a substantial portion of the members within the uninsured population. And then you have some within the commercial, primarily within Cigna, the government programs. And in this case, when you look at the middle segment, there are some of the key areas such as obesity or chronic conditions, obesity, diabetes, colonoscopy preventive care, and mortality for infant mortality rate. You could see the comparison between USVI and mainland, where USVI is somewhat higher. And this all necessitates two things. One, there needs to be a macro level thinking in terms of how to finance these different care programs so that the model is sustainable. And two, as part of it, like what role providers, hospitals, health systems, FQHCs, primary care in Virgin Island, how do they work together, work with the government, and figure out a new model to scale this healthcare ecosystem within the island. Next slide, please. So one key data here is, as I'm sure some of you may know, when you look at it from a benchmarking perspective, Virgin Island, again, because of the cap model, the mainland gets a different share in terms of spending within the Medicaid population, and U.S. Virgin Island, compared to other territories, they're doing pretty good, but still there is a gap between mainland and Virgin Island. And this gap is another stressful factor that's going to contribute to the economic framework that already exists in the island, and that would bring different stakeholders, providers, and others in the market to work together to build out a new transformation model from a financial standpoint. Next slide, please. So what we do at Chartis is specifically working with community providers or community leaders. We try to focus on three aspects here. One is focus on the preventive care. Yesterday, Governor stressed about preventive care based on why do these utilization happens. And in order to focus on the preventive care, the first thing is one needs to understand the journey of the patients itself. Like, where do they come? What are their social factors? What are their healthcare factors? What are the other factors that are contributing to their overall healthcare utilization? So that's one. Two, follow the financing aspect of the patient itself, whether the patient is in Medicaid, fee-for-service. I understand Virgin Island doesn't have MCO model, but from fee-for-service, as the patient age into Medicare, then now how do you now capture additional premium dollars from CMS and federal, and so that you could reduce the cost internally? And also exchange and as they navigate and graduate when they get the employment in the commercial side. And then there is also a substantial or a significant portion that continue to exist in uninsured. And what we have done is all the uninsured or underinsured, usually it doesn't come within the traditional product to manage them from a care perspective. For some of the community hospital systems, we have built a managed care lookalike model so that the health systems can deploy different clinical and network strategy to reduce their ED cost, IP cost, readmissions cost, and also move the care more from a reactive to proactive basis. Next slide, please. When we look at the economic model, again, from a health plan, so in this case, it's going to be Virgin Island, but also from a provider perspective, what are the key levers that you would integrate between the provider and, in this case, Virgin Island? Again, when you look at the economics, from a provider perspective, you have fee-for-service spending, but also what are the different capitated models, VBC models that you have within your network so that you're able to work with the Virgin Island territory and stakeholders to manage the care more efficiently by also managing your premium dollars, right? So today, a patient goes sees a provider, provider sends a claim to Virgin Island Medicaid, and the provider gets reimbursed. In a capitated model, if providers have access to these dollars more upfront in terms of capitation, then those dollars can be used for investments, whether in a clinical infrastructure, network infrastructure, or social infrastructure. Likewise, when you look at it in a premium model, you also have like other investment strategies, primarily because of the premium that you collect and then make investments in non-healthcare infrastructure in order to scale your model. Next slide, please. With that said, there are three possible scenarios that we have seen play out in mainland states that used to be in a fee-for-service model, such as Virgin Island is one. Primary care-enabled risk management, where there is a capitated model for primary care providers working with the stakeholders to take the risk and reduce the total cost of care, whether from a disease-specific perspective or disease-agnostic specific. Then the second part is more accountable care network or clinically integrated network. Both are pretty much the same with some governance changes, where it's primary care plus secondary plus tertiary, and all community providers come together, work with the state and other stakeholders to move into a capitation model so that the providers, you are taking the risk and also reducing the cost of care on the downstream. And then the last one is a full-blown MC or managed care organization, so where some of our clients, partners who are community health hospitals, we have helped launch their own health plan in that specific community so that they have not only provide clinical care, but also they are able to influence and manage the financing of the care for their population. Okay. I know there are other details, but in the interest of the time, we'll leave it here. And again, I'm Pravit Nambiar. If you have any questions, happy to answer offline. Thank you.
Hello. And by the way, I am putting you up for best socks. You're in the running. Thank you. Karen, I'd love to hear what your thoughts are and what you're seeing in terms of trends.
So, this has been interesting to listen to all of the different, first of all, I'm really excited about all the work that I have heard since I've been here that everybody is already doing to pull energy and to pull finance and to pull intention and attention towards the USVI and to the territories. But what I wanted to share maybe is in a bit of a different, it's from a different viewpoint, and that is, again, with the big asterisks, based on my personal experience and lessons learned, basically things I broke and had to recover from. There's this little lady, she's not a little lady, in my experience, she's a big lady, named Carolyn Robinson, who works at CMS. And she ran and trained me up in finance, budgeting, and accountability. It's an important part, accountability. For federal tax dollars and state relationships, et cetera, and credit scores. And so and she was responsible for all of the IT funding for CMS. She was the funder for all the budget, the whole budget for, and IT in CMS, the IT funding is how everybody else in the agency gets their implementations done. And so I found myself in her tutelage in December 2013. October 1st was when ACA, healthcare.gov, failed to launch appropriately, when I was pulled in to figure out how to help with the recovery effort, and I was responsible for the implementation, and for the first time, responsible for a $2 billion budget, completely overwhelmed, completely over my head, and she's this amazing little lady. She just said, it's no different than your house budget. Everybody should have a business plan for what they want to do. They should compete for what you have. You should know what you have, and you should know what everybody needs. And then I will teach you where to go to get it. And that every Friday, every 2 weeks, she and I would go to Ruth's Chris, and we would sit and close the restaurant down, going over the ACA budget on a cocktail napkin. I am not exaggerating. And she would teach me, and I would say, well, I want to do this. She's like, that's not how you start. She said, a budget is not a request. it's a justification. You start out with what you want to do, what's going to make it better, and then you tell them how much that's going to cost. You got to get them excited about the outcomes first. What are you going to do with the money? You have to show that you have a strategy, and you have to be willing to be annoyingly interrogated to the nth degree about if the things you said you were going to buy are actually coming to fruition, because that's the accountability piece. And that's how you build up your credit score, so that when you ask for money, you get to a place where you start becoming someone, to the people who have the budget, you start becoming someone who does what they said they were going to do with the little bit of money that they gave you. And so when the government gets new money and they're trying to figure out who should they give it to so that the agenda can be implemented, you become someone who is known to have a high credit score. Give it to Karen, because she knows what to do with it, and she's not annoyed when you ask her 70 times, are you spending it? What's the data look like? What's your North Star? Are you hitting your North Star? And you proactively say, this is the money I want, and I am willing to meet with you every Wednesday at 2 o'clock to tell you how I'm going to spend it and how it's going. Golden information, best education I ever had. So when I left CMS and I went out into private industry, I used that same. And then when I went home, I was annoying everybody at my house with the same thing. So if you have a dream, and so first of all, I just want to validate and say out loud, I recognize and I'm really excited to say out loud, you are the smartest persons. The people who live here know what's best for this island. And so there are people who have money who want you to validate that you know what's best for this island. And so my recommendation is that you use the same model that you do for software requirements. You do requirements assessment for what the person needs to know in order to give you money. So what does OMB local need to know? What does OMB federal need to know? What does CMS need to know? What do your plans need to know? What does the governor, what is everybody, what is your, basically it's a personalized, customized profile for everybody who has a funding stream and what they need to know in order to put you at the top of the priority for their limited funding stream. And then you make a business case and you increase your credit score. And so Gary and I have been having conversations about the fact that the Medicaid funding increase for the match comes with a strategy. That's a gift. It is a gift because that is an opportunity to demonstrate that you know how to handle every investment that they make in what you want to do. It is said a million times, but I can't say it enough times. We have a greater responsibility with any tax dollars that we get or any grants that we get to make sure it's spent well, because it's so limited and it's so contentious and it's so political. And so the more you represent a good steward of turning this money into positive outcomes, the higher your credit score. So this is a true statement, and this is all going to be recorded, so CMS is going to know it. When I left the agency, I was the senior career executive responsible for the Medicaid and CHIP federal budget. And when I left the agency last year, there were exit interviews, and of course nobody really realizes that you're leaving until like the week you're leaving, and everybody wants to meet with you and talk about everything that, you know, your transition plan, which was a month-long transition plan that was shoved into a week. And so there were meetings and everybody was going, okay, what about this? And what about this color of money? And how do you get this? And it's the same thing you do. Everything you do here happens at an exponential level at the federal government as well. There are 8, if you look at the org chart at CMS, I think there are 8, maybe just there's a new org chart, there's 9 groups. Each one of those groups in Karen's budget Bible, that's what I called it, had a credit score. Which one of those leaders, if I only have $100 that the agency has given to me, which one of those leaders has a good, strong business plan with design outcomes for what they're going to do to implement the Medicaid CHIP agenda for their program? And if I have someone who's got a weak credit score, that's where I usually would send some educational contracting dollars, right? And so I guess my overall advice is all of this information is really helpful, but the bottom line, it is basic budget management that requires you to demonstrate that you personally and your team personally and your agency personally and your department personally has respect for the intention and the outcomes that this money is going to be given to you in order to implement. And when you show up like that, it's hard to say no. And so think about what you would need if someone needed to hand money over, you needed to hand your money over. Like, what kind of accountability contract would you require? And if you exceed that expectation, you get to the front of the line every time. It is very consistent that when you hold yourself personally accountable for the money that you ask for and you demonstrate stewardship over that, money comes to you. That's all I got.
Thank you. So Alexander, I'm going to turn to you next. So besides having lunch with me every other Friday at Ruth's Chris, what do you think would be important here on the island or within the Virgin Islands to make sure there's an accountability structure to get the outcomes and results we want?
So I would support your suggestion and your tips in which you have consistent communication and also share your basically brag about what you've been able to achieve. Be public with what you've achieved and let people know what you're about. It's the most important.
Yeah, so that actually comes back to the tip of being transparent and public with your data and your information, acknowledging and ultimately celebrating successes.
Exactly.
Yeah. So as you sit here, Pravin, and you're listening to the conversation going on, any additional insights in terms of what you think would be important in terms of funding and cost transformation?
I think Karen made a great point in terms of how do you write a business case and specific to a project and then build multiple business case into a broader enterprise project so that as you execute the projects, these business cases can be measured in terms of their delivery, so that you can go back to the stakeholders and show whether it's a 2x ROI or 5x ROI or 10x ROI. And then the second part, and Karen, like the point you were trying to make is, in our experience working with common stakeholders, the moment you show the ROI, you can start building a self-funding model. And what I mean is that in Chicago, Illinois, we launched a housing program for one of our community, large safety net hospital, where the initial fund came from the board, but then as part of it, like we started looking for patients who are costing $80,000, $90,000 per member per year, and addressing their ED, IP, medication adherence, we could reduce the cost to 38 to 40%. And then what the board allowed us to do is like not only expand the housing program that integrates medical and behavioral health care, but also it asked us to reinvest those 38, 40% of the savings to expand the seat. So what started off as a pilot and demonstration for 66 members, currently they house 250, and that's how we built the self-funded model. So having the self-funding approach so that you can demonstrate the value, and then you can also drive the journey from an ownership standpoint.
Awesome. Karen, you got a few minutes left. Obviously, you got a lot of passion for this work, and obviously, you've got a lot of ideas around managing your budget, both personally and as an organization. Any other thoughts you think would be important for this audience as they think about next steps?
No, just allow all of your PMOs and your project managers to help you continually, constantly search for grant opportunities, new regulations that get passed, like the budget. Every budget is your friend. Look at it and see what the current agenda is funding, and be okay with flipping it around. Like if you've personally got 10 priorities, look at what the budget is focusing on and move your priorities around based off of what the administration is leaning toward and willing to buy.
All right, last question here for Alexandra. Why do you think the U.S. Virgin Islands are having as much success as they are having in attracting more funding, particularly from the federal government?
Well, we have an excellent track record. We do what we say we're going to do. We report accurately. And I think that once you are able to demonstrate your ability to deliver, you develop what's called a good credit report.
All right, well, last thing I'm going to say here, shameless self-plug. Once again, socialsectorhero.com, you can download the book for free. 8 core strategies that I think any government, any funder can use to improve performance and get better outcomes for their clients and their community. And I actually have about 20 copies in the back of the room. I'm happy to sign for the first 20 that come to it. So thank you for that. And thank you, Michelle.
Before I let you guys go, I do have a final question for anyone who might want to respond to it. There's an issue at times with when you actually receive the funds and the ability to then spend them down. If you have a small team, you got a large amount of money, any tips on how to effectively and efficiently spend the monies that you are awarded?
I would just say that should be in your business plan before you start. You should know what you need. You shouldn't ask for more than you need, and you should have a plan to spend it down. Like that should be a part of what, like the planning stage should be most of the work and most of the time you spend before you get the money.
I'd like to add also, when writing your business plan, part of that is development of, your objectives, how you're going to go about spending the money, breaking down your budget into attainable sectors, and also possibly doing your projects in phases. So if it's a very large project, it's like having a big elephant, a small bit at a time. So phases help you also.
And one more suggestions would be, as you put together the business plan, looking at the cost as a fixed and variable, and what's one time versus ongoing. And this way, you would understand your fixed cost internally, and then any surplus funds that you have, you can get external help, which is outside of your internal labor.
So I know all of you had a lot more that you could share. I feel like we could do this for a few hours with Q&A back and forth. But please make yourselves available. I know, Pravitha, especially you have additional slides, and I'm sure there are any number of folks in the room who would love to understand more about the self-funding model. How do we get there? Et cetera. And I think having your free tips, those 8 strategies, are really helpful. I think that's something helpful to bring back to any team, to say, what can we glean from this? How do we personalize this as an organization? So, and then any questions about funding that's here in the territory related to broadband, Alexandra and Daryl Wade, I know are here and can answer. And your team. So thank you very much. Please take advantage of these guys and their respective expertise. Thank you very much.
Thank you.
So as we transition here, I'm calling all men wearing socks that you want to display. This started out last year inadvertently. This year we're doing it intentionally. And as mentioned, there is a prize involved. So, do we have anyone proud of their socks that wants to show their socks off? I'm gonna pick on Damon. Oh. Chairman Finch. Oh, you came ready today. Yes, I love them. Yeah, but you came ready this year. I like it. I like those. Okay, this is gonna be easy if you guys are gonna be shy. Oh, all right. Wait, you gotta come up here, because these giraffe socks, I think, are impressing me. And Pravitha, you gotta come up here. Let's see them. Come on up. Oh, okay. So we're getting excuses. There would have been fancier socks if they knew there was a prize involved. Yeah. I think that was announced yesterday. Am I wrong? Okay, let's see. Pull up the. Okay, let's see. Come on, Damon, get up here. with a little medical theme going on. You got to come over here so everybody can see. You got to get to the center. Gary Smith, where are you? Oh, we've got, oh, yeah. All right, let's see what we're working with. Oh, with a little bit of leg shown as well for extra points or points deducted. Come on, Director Smith. I think he feels confident, so he was the last to the stage. So this is going to be an audience vote. Oh. Is the heel pink? Is there a little pink in the heel? Yeah. So let's see. Yeah, okay. All right. So audience, we're going to go from my right to my left. We've got, let's see the giraffes and the bright sunny day. Whoa. No. Okay, not that exciting. The heart rate just went up, so show us those heart rate monitor socks. Yeah. All right. Music, please. Music, please. Hey. Okay, so I think it's between the gradiated color and the giraffes. Okay, so giraffes and gradiated color. Could we have a little music, please, as we decide? All right, so let's hear it one last time between the two of you. So, the heart rate? Okay, so it's three. It's heart rate, giraffes, and the gradiated color with a little splash of leg. Okay, so giraffe. Let's hear it. Heart rate. Oh. Yeah, those are high. All right. So it's between the two. One more time here. And at the end. Okay. Well, I've got three.
Thank you.
Thank you. Thank you all. Thank you, gentlemen.
All right, thank you.
So that woke us up a little bit and has got us prepared for our Department of Health team. I think all of you are going to appreciate being able to, again, we tried to sprinkle throughout the days, being able to hear not only from experts who've come from off-island, but from our teams here in the Virgin Islands. So we're welcoming to the stage Commissioner Justa Encarnacion, Dr. Esther Ellis, and who else is on? Do we have a Suda? Yes, she's coming to the stage. Yeah. Okay. Perfect.
I'll wait until you finish.
Are you going to stay on stage?
Yes.
Okay. So we'll need some mics. You're going to all come up and present? So we do need 3 mics. So remember, there are snacks available. Grab your snack and come back in. And may I ask, I don't think my breath stinks, and I don't think you could smell it from the front row if it did. So can y'all pull up a little bit, pull up a little closer? It's like church. Everybody fills in the back. The blessings come from the front down, so come on, pull in closer. But you are VIP. Everyone is very important. Okay, we're starting with Commissioner Encarnacion. All right.
Good morning, everyone. That was a good little wake up, but Michelle, where are you? Right. Okay, good. So I think that next year, because it will be a next year, we need to actually have the women come up with their heels. Okay? So we're going to do that challenge, right? Okay, good. All right, because I really enjoyed that. So congratulations to the two that won. I love that. Let me just start by telling you a little bit about the Virgin Islands Department of Health, other than it being the awesome department that we have within the territory. By law, the Virgin Islands Department of Health is responsible for providing public health services to the people of the territory, which involves protecting and improving the health of our community through health promotion and preventive initiatives. Preventive measures are widely recognized as key components of efforts to improve overall health and reduce healthcare costs, particularly related to chronic disease. The emergency support function, ESF 8, which we all experience EFFs when especially during hurricane time and any kind of disaster like the pandemic. During emergency status, the department also oversees hospitals during a declared emergency or disaster. We'll be hearing from Suda, from Hummingbird, and Esther, our territorial epidemiologist, later on, who will be speaking to you about some of the things that we've done. Measuring, promoting, and advocating for public health on a global and local scale has proven to be challenges. I think that's just all over. Public health benefits from data-driven decisions based on data that is collected systematically and accurately. As we continue to increase the use of data in public health, we first ask, how real is that data? How can we validate the usefulness of the data, and what practical applications can be added to data gathering to ensure that we are looking at the issues being discussed and felt in the homes of the people we serve? Public health informatics is a systematic approach application of data technology and information systems to public health, practice, and research. Focused on community and population health, it tackles disease, treatment, and prevention, as well as examining the roles of government agencies in public health. The gem to all of this discussion is our community health workers and the information they gather by introducing themselves in our community of need, gaining trust, creating opportunities to introduce ideas for change in a consistent manner so we can actually see the change. We will arm them with the tools they need: computers, software for information and data sharing, and training. We currently have 5 certified community health workers throughout the territory. We have many outreach workers, different frame, different name. However, what we plan to do from here in is look at what our outreach workers do, train them in the realm of community health workers. Right now, community health workers don't make as much as other outreach workers, depending on the scope of work that they actually do. But why not? Arm them with the same weapons that we do our community health workers, especially since throughout the nation, throughout the world, we have actually been seeing incredible outcomes with the data based on the work that community health workers are doing. My thought is, why not create a robust team of community health workers and expand the program with the goal of expanding positive health outcomes. Our goal is to improve health equity by implementing a culturally sensitive approach to identifying determinants of health within our territory. One of the things that we do here in the territory, we eat a lot of carbohydrates, a lot of starch, a lot of salt. Hence, we have high numbers of diabetes. We do have high numbers of cancer as well, cardiac illness, hypertension, stroke, and chronic illnesses we live with daily at really high levels. With the use of information technology and the compassionate care through our community health workers, we can overcome this. We may not see the results today, but it's something that I can assure you that we'll see the results of the future. You'll also be hearing from our Assistant Commissioner Malloy, as well as some others in a panel that we'll be having later on throughout the session that speaks to actually some positive outcomes that we've been having with the use of our community health workers. Currently, we have a cancer registry. We have our immunization registry. And got some great word yesterday that we're going to be able to develop a diabetes registry with some funding that we're looking forward to receiving. I want to speak too much about it because we're still pending confirmation of that. That is actually going to allow us to look at our data from a demographic standpoint, create what we look at, what we did during COVID, and that is a more of the boots on the ground approach to healthcare, and actually seek changes. One of the other things that we will do, you know, you listened to Chris, the president, with the CEO, as well as the chief medical officer a little earlier on. You've been hearing from our executive director of the health IT, Office of IT. I think one of the things that we will be doing differently in the future is having more conversations, looking at what we can do collaboratively, from a public health approach, inclusive of human services, inclusive of hospitals, federally qualified health centers. We, in the Department of Health, and you can go to our website, we have a couple things that you can look at. We have our strategic plan. We have our health, our community health assessment. Based on that, we've created a community health improvement plan. When you seek it, actually, you're going to be looking for the public health. It's a territorial Territories 2030 Health Improvement Plan. So when you're looking for that, that's the things that allows us to best see exactly what we do, what we're doing in our community, what we can do differently, but we cannot do it by ourselves. None of us can do it by ourselves. We have to be able to do it together. Finally, the last speaker spoke about what we can do to ensure that we're improving throughout the territory. And we spoke about creating giants of each other's. We spoke about sharing our successes. So now I'm going to hand it over to Dr. Ellis. She's going to share one of the biggest successes that we've had, and it came with our efforts during the pandemic. Dr. Ellis?
Good morning. Let's try that one more time. Good morning. Wonderful. It's so wonderful to be here. It really is an honor to get to present to you this morning. I'd like to thank Director Michelle Francis for putting on this summit and bringing us all together. Also, Dr. Sandra Ford, who I know is also speaking again later today, for her amazing keynote address yesterday, all of which is directly applicable to what we are currently working on and striving towards here in the U.S. Virgin Islands. I'd also like to thank Commissioner Encarnacion for her leadership of the Department of Health and commitment to health IT. I'm going to present today some of the data that we have collected and disseminated, the U.S. Virgin Islands Department of Health Epidemiology Division 2022 annual report, and also tie this in to some data modernization efforts. I think they're still pulling up my slides, but we can, once the slides come up, it would be the next slide. Okay, great. So this is the cover of our report. And actually, next slide, this is pictured as a table of contents of the actual report. The report is 15 pages, and many of the details of the report we don't have time to get into today. I know you can't read that, but really this is kind of a taste of the report, and I encourage you to go to the Department of Health webpage and download the report. Also, if you have your phone out, you can scan the QR code pictured here or on the screen there, or I can help you find and get the report later today during lunch as well. Next slide. The Virgin Islands Department of Health Epidemiology Division conducts surveillance of nationally notifiable diseases needed for disease monitoring, analysis, and timely reporting of findings to guide public health policy and decision making. Below really pictures what we do, and I'm proud to be able to contribute to bettering the health of our communities. Epidemiologists and our activities were pushed to the forefront of public health during the COVID pandemic because of our vital function and role in generating, analyzing, and disseminating the data necessary for improving health. We can't escape data. And I'm sure after all we've learned yesterday and today and will continue to learn, we know that we can't escape data. I'll just start with a little bit regarding COVID, because a lot of lessons were learned during COVID that are important to our current modernization and digital health. Nationally, it becomes very clear that it took too long to access data, important to responding and improving health. COVID was and is a major force in the need to accelerate information technology and data sharing for decision making at both local and federal levels. Next. The size and strong connectedness of the Virgin Islands was important in the success of COVID activities in the Virgin Islands. If we go to the next slide, you'll actually see our COVID EPI report. So our agencies worked really closely together and included the governor's office, healthcare providers, laboratory schools, nursing homes, the community, and others. The Department of Health was able to quickly share our data with the community, and we continue to share weekly reports with the territory. As you see here on the weekly report, you can also get these from our website. But nationally, a number of challenges were clear. 70% of healthcare organizations used fax to send or receive care records. You heard yesterday from Dr. Ekpo, we still receive many faxes and have to enter that data by hand. Up to 80% of epidemiologists' time was spent cleaning data because of non-interoperable systems. 6+ months was often needed to develop and potentially rework data use agreements, and 12+ months for data on some reportable conditions to become available nationally. And those challenges were still there at the national level when it came to the recent monkeypox outbreak. Here is background socioeconomic information from the EPI annual report. It provides a good overview or background for the annual report, but it's also critical to understanding and improving health at a population level and addressing health disparities. And this became abundantly apparent during COVID and is often challenging without efficient reporting mechanisms and standards. I'm going to highlight two characteristics from these demographics. First, insurance. I know we heard in the last session about insurance, but of 84,630 persons reported by household, the number of individuals without insurance is 20,825, or 24.6% of our population. Of the individuals with insurance, the 75%, 46 have private health insurance and 37 have medical assistance. And the proportion of uninsured persons was almost 3 times the national average for uninsured persons in 2020 compared to states, and that is 8.6%. So just if you think about health disparities and health equity, 24% uninsured versus nationally 8.6% puts us in a very unique position here of underserved, undercared for individuals. When we focus on public health and epidemiology, we often focus at the population level or subset of that population. And accurate and timely data is critical. I have pulled a portion of the previous page out here larger to highlight our 2020 census data, which indicated that the population of the U.S. Virgin Islands decreased by 19,259 individuals, or 18.1%, which leaves our population now at 87,146 residents. And on the slide, this decrease differed significantly by island. St. Croix reported a decrease of 19% of residents, St. Thomas reported a decrease of 18.2% of residents, and St. John a decrease of 6.9%. Next slide. Using the new population data, I'm really excited to highlight a project that Dr. Katie Laubgold, our Epidemic Intelligence Service Officer, worked on titled Estimating Bias in COVID-19 Vaccine Coverage Under Changing Population Sizes. We at the Department of Health have been able to host and train 3 EIS officers over the past 6 years in collaboration with the Centers for Disease Control and Prevention. And on the next slide, it shows some of the biases that she found. In considering differences by island, using 2020 population counts, you can click to the next, vaccine coverage estimates were 11% points higher for St. Thomas, and we'll click again and see St. Croix were 11% points higher as well, and click again, St. John 6% points higher for vaccine coverage if comparing the 2010 census data to 2020 denominator data. And in the report, you'll also see a snapshot of some of the work that EPI has done. Successful efforts in protecting and improving the health in the territory has not only been limited to COVID. And in the last few years, there were a number of achievements that I think highlight the importance of data and the strengths we in the VI, being small territory, have to improve health. First, because we're a small territory, we work intimately with our community, and our community is willing to participate in public health efforts to improve health. I heard a lot of talk yesterday about trust, and the Department of Health is a trusted source of information, a trusted entity. Secondly, we work closely with our Department of Education and our youth to do a lot of training in the schools. And third, we identify and investigate unique aspects of our territory and health. If we go to the next slide, I'm going to pull out one point from the previous slide about our U.S. Virgin Islands dengue epi aid. We conducted a sero survey of children in the 3rd to 7th grades during April to May of 2022 to determine the prevalence of past dengue infection in the age group eligible for dengue vaccination. And I would like to thank Dr. Valerie Mack, who led these efforts. 15 schools across USVI hosted a dengue day in which nearly 1,400 children participated, receiving a health education program where they were, quote, disease detectives or young epidemic intelligence service officers in training for a day. It was really fun. In addition to the health education program, children with parental permission received testing for dengue antibodies using a dengue IgG rapid diagnostic test. Among children aged 9 to 13, which is the eligible age group for the dengue vaccine, we actually found that nearly half had previously been infected with dengue virus and had not been previously diagnosed, which is very critical to understanding that there needs to be more education, there needs to be more access to testing, and potentially the availability of the vaccine here. On the next slide is the list of USVI notable conditions. I know Dr. Ekbo talked about that yesterday as well, but one of the primary areas that the epidemiology division is involved in is the notifiable conditions. And this is an area that data modernization efforts can have an important impact. Next slide. And this is our paper form that people still fill out by hand and fax in. But we are working with Hummingbird Health, and you'll get to hear from Dr. Sudha Megan next, in creating a web fillable form. We also work, as Dr. Ekbo talked about yesterday, with providers directly to meet them where they're at, whether they can send us a CSV file or send us HL7 messages. The hospitals are sending us HL7 messages for reportable diseases. We'll meet anybody where they're at so that we can get the data and have the most complete picture possible. On the next slide is the general communicable disease surveillance that we've done. And the numbers that are listed here talk about hepatitis surveillance, vaccine preventable diseases, foodborne and waterborne disease surveillance, healthcare associated infections, and other communicable diseases such as hand, foot, and mouth disease. We also focus a lot here on vector-borne and environmental diseases, some of our mosquito diseases like Zika, chikungunya, dengue, yellow fever. And we do have a page dedicated to our COVID data for 2022 only and what we saw in 2022. this is a list of all of our publications from 2022, so it's on the next slide. Another reason, and one more, another reason why it's really important to go ahead and grab this report so you can read some of our important publications in peer-reviewed journals. But a few that I can highlight are seroprevalence and distribution of leptospirosis. On the next slide, spatial and sociodemographic and weather analysis from our Zika outbreak. Next slide, the Public Health Branch Incident Management and Support in response to Hurricanes Irma and Maria. Next slide, assessing rodents as carriers of pathogenic leptospira species in the U.S. Virgin Islands and the risk to animal and public health. Next slide, preterm birth among pregnant persons who got COVID while they were pregnant. As well as next slide, microbial characterization and factors contributing to contamination of household use of cistern water. So the majority of the water that we use in the Virgin Islands is collected on roofs. I'll just highlight here that E. coli was detected in 80% of 399 cisterns tested and 58% of kitchen taps, which means that there wasn't proper filtration happening on the cistern water prior to going to the kitchen tap, and that's definitely an area that we can work on and improve. And then the last paper that I'll highlight is a cross-sectional household survey, also showing that cisterns are breeding habitat for mosquitoes. And on this page, which is really a direct cut and paste from our EPI report, is all the contact information for the epidemiology division, the emails, and so if you want to contact any of us, feel free to grab this from the report. And I'd just like to thank you, the audience, for your attention. My email is listed here, my cell phone. You can grab this report from doh.vi.gov. And I'm really excited that Dr. Sudha Megan, who is we at the Department of Health have had the pleasure of working with over the past few years, is going to talk more about how some of our data innovations have allowed us to better collect and connect our data more, and more from a broad process improvement angle. So without further ado, Dr. Sudha Megan. Thank you.
Good morning, everyone. I am Sudha Megan, and I must say it is an absolute pleasure to be here, to be on island, to meet all of you, and to be driving on the left side of the road. I have had the honor of being able to collaborate with Dr. Esther Ellis, Dr. Brett Ellis, and with the leaders in their team, Dr. Lisa Ekbo, Dr. Mara Lawrence, around innovation for the public health department. So to take a step back, Hummingbird Health is a social impact organization. We focus on digital health for public health organizations. And in that, we're incredibly committed and focused on resiliency and sustainability of solutions. We'll talk today about some of the work that we've been able to do, and we'll also take a spotlight approach of some of the best practices of data modernization and what some of the other individual nation states or territories and states are doing around the world that we might be able to glean from. So let's think about the Virgin Islands. Very, very unique considerations and unique challenges that we all know about. The culture. Being able to, we talk about cultural sensitivity. I would say we take it a step further and we talk about cultural fluency. Being able to understand how people understand health. We've been working on a collaborative initiative, on a documentary, looking at African communities, part of the diaspora around the world, and how they look at art, culture, music, and how they engage with health. What are the stories and what are the narratives that would be valuable to be able to enable access? Then we think about language. And this is beyond the words of English, Spanish, Creole. It's about the words and their meaning. It's about how do we enable individuals to advocate for themselves, and how do we empower the boots on the ground, the public health teams, to be able to communicate in a way that information can be easily understood. From a geography standpoint, I'm told Water Island doesn't count, but we think about it in terms of the islands. We also need to think about it in terms of the streets, the locales, in terms of the proximity to mainland. We heard from the governor yesterday a narrative around to be able to go to access care outside of the island is a significant investment. And what does that continuity of care look like once you're back home? The weather, of course, looking into hurricane preparedness, hurricane rebuilding, and from the standpoint of what is the information that is incredibly valuable to bridge together these moments where people feel the most vulnerable and where responsiveness and speed and agility is critical. The economy, right? Like we think about the jobs that people have and how health can be incorporated and touch people where they are. We also need to think about how we look at health both of the local individuals and also the engagement with the tourist population. And what are the resources that we're going to allocate from that standpoint? And finally, digital access. You know, the most delightful thing about driving here the last couple of days has not in fact been driving on the left side of the road or you know, the stone walls that are 3 centimeters away from my Cadillac 300. It's been sometimes I don't have cell signal and the maps are telling me to take a left off a cliff, right? So it's about thinking about what does our connectivity look like, including the plans for broadband access across the territory. It's also about looking at how in certain homes, and we witnessed this firsthand during the COVID pandemic, families share mobile phones. They share a phone number. And so how do we make sure that data and privacy is protected as we share and engage patients, say, for example, with their test results? With all of these unique challenges and considerations, though, it also makes the U.S. Virgin Islands a beautiful place to be able to realize the gains of digital transformation and data modernization. So when we think about the vision, right? When we think about best practices, what is critical is being able to have operational fluency. So technology needs to be braided together with the people and the processes and the individuals that essentially weave together the actual deployment. It's also about creating community-centric care, being able to understand that some people feel ping-ponged in the healthcare systems and in the public health sphere. One of the most inspiring stories as we thought about the social impact focus for Hummingbird was some of our own team members work with foster children and working together as social advocates for these young children. There's one girl that always comes to mind for me as I worked with CASA. Her name, she called herself Dolly, which was in fact also the name of her doll. And just understanding how she needed to get her meds, basically like an inhaler, right? And not knowing which pharmacy to go to. And then not knowing how much to share with her family doctor because that wasn't her primary doctor anymore. Knowing where do schools fit into that public sphere. And also being able to bridge together those resources that are in the community so people have access. This kind of takes that ecosystem lens to public health and data modernization. All right, so let's do a quick review of some of the initiatives that DOH has been able to achieve that Dr. Esther Ellis and Dr. Lisa Ekbo spoke to previously. One has been around data collection. And Dr. Sandra Ford said this best yesterday. If we don't ask the question, we won't have the data. We won't have the information. And once you have it, what do you do with it? What type of engagement or analysis can you have? Part of this was around enabling digital reporting of private providers in the community. It was also about being able to capture the data determinants that we wanted to study. For example, social determinants, some of these were health and human service requirements at a national level. And then it was about looking at how do you report this, both to the local territory case management system, as well as from an anonymized standpoint to the CDC. Then we kind of look at testing. The Territory Public Health Lab, and being able to bridge that together with some of the field operations that the public health and the Department of Health teams were able to engage the community around testing, whether this was when people were symptomatic, exposed, or for schools when they were coming back. And being able to automate these workflows and create a workflow meeting, again, systems and people where they were, right? A graduated approach to integration and interoperability. Then we kind of looked at pre-visit surveys. So before an individual had a testing appointment, how about we enable them, empower them to report their own health data? Are they feeling symptomatic? Have they been exposed? This also enabled the Department of Health to guide resource allocation and do eligibility assessments so that when there were peaks of cases, you were able to prioritize which individuals were able to get care at which different community centers. And then finally, touching on secure case reporting, and kind of, again, graduating individuals and provider groups from paper and fax-based systems to digital networks. So now what we'll do is kind of look at data modernization across the globe and from terms of best practices. All right, so we talked a lot about unifying the patient journey between their different touch points across departments of health, also connecting to existing resources and being able to support the community in a scalable fashion. So what does this mean? Some of the work that we were able to achieve through COVID-19 was then able to be extended to HIV testing in the community. Exact same model where people want to get tested, there are events, and people are able to securely receive their results. And finally, again, going back into engaging with the boots on the ground, engaging with the field teams and laboratory teams, and giving them the tools that they need to be able to engage effectively. Continue. All right, so one of the really neat aspects about the Virgin Islands is its locale in the Caribbean, as well as the relationship with the mainland, right? And so from that standpoint, what would be really helpful is to kind of think about what are some of the other innovations that other entities are doing. So Jamaica in 2022, in partnership and funded by the Inter-American Development Bank, looked at what would it be for patients to be able to self-report and monitor their activity, their nutrition, and their day-to-day living. It kind of goes into the appetite for mobile health and the accessibility that it enables where there are decentralized systems and where there is disparity in terms of who might be physically able to go in. We also look at advisory around natural disasters. There have been several studies that have demonstrated how mobile health engagement has essentially enabled community members, right, local leaders, to be able to communicate best practices and collaborate with the emergency management agencies as well as with EMTs. And then finally, kind of taking a spotlight into, we've heard a lot about maternal care. There have been studies that kind of look at prenatal care, particularly for Caribbean women, in the context of what would be resonating with their day-to-day lives. One of the critical aspects has been that many people have felt excluded by some of the offerings that are currently available. And again, we come back into cultural fluency. When there is an emotional familiarity with specific foods, and there is also a lot of cultural narratives that need to be addressed and dispersed, you tend to understand the importance of interacting and engaging with social circles as well as with creating a mobile health solution. You also need to think about the socioeconomic status of individuals for recommendations such as nutrition guidance, right? In terms of what do people actually have access to, and is this relevant to them? And all of this to say that when we think about data modernization, when we think about understanding a culture and a people, it's also at an individual level, right? We take, for example, a lot of the work that has been showcased recently in generative AI. And that's basically a fancy way of saying that there are technologies that enable people to create content, for example, health information articles tailored to specific needs. If we're able to do that at an individual level because we have this data, it makes it a much more nuanced and personalized experience. Continue. All right, so when we think about looking forward, one of the key facets that we're incredibly passionate about has been around the ongoing management and maintenance of systems by the people that we are partnering with. And so that involves a couple of tiers of approaches. One is being able to gauge ongoing feedback and essentially prioritize and scale solutions, right? Where else can we engage with notifiable disease requirements? And it kind of takes that problem-based approach as opposed to trying to figure out what holes the technology can fit into. What problems are we solving? Also, I mean, like interoperability is the magical word of the week in terms of thinking about how do systems talk to each other, and again, looking at this from a stepwise standpoint, right? Like what are the processes and how do people fit into these workflows? And then finally, again, we look at it from a product approach in terms of there is a platform that essentially the local IT teams and the local public health leadership can take the reins in terms of creating their own experiences and guiding the workflows that they want the community to engage in, whether this is setting up the eligibility survey for testing or for being able to access other community resources. With that, I wrap again with a lot of gratitude. It definitely takes a village, and tremendously grateful to Director Francis for hosting this event, for all of the individuals that I've been able to meet so far, and looking forward to meeting many more of you. And I'm also really grateful to our advisors and my team, an incredible group of passionate and dedicated individuals, some of who've started their careers with us, some of them have left corporate America to join us on this journey. And we're really, really excited to see what USVI has on the horizon. Thank you.
Here. Thank you so much for that, Sudha. I really want to say thank you. IT and what we're doing in health is critical. And we heard a lot about what epidemiology is doing, and please go on the website and look at the report. I was truly impressed. I shared it with everybody I could think of, because there's so much data in that report right now that I think that it will give you a lot more just by looking and reviewing what we've done. EPI is only one of the areas that I think that we're very proud in terms of how we're capturing data. Communicable diseases have been really doing an excellent job in capturing data and looking at how we actually improve health and wealth. I have to tell you that the 340 Getting to Zero is something that we all know now in the territory, how we're looking to reduce HIV within the territory by 2030. Our public health lab, I know Sudha, you spoke about Dr. Brett Ellis and our public health lab. I look at him basically as our silent Dr. Ellis. We don't see him, we don't hear him, but he does incredible work in the lab in looking at collecting data. We are now able to test for STDs, many levels of STDs, numbers of STDs than we were in the past. So we're able to collect local data. And we're speaking about public health and IT. Sometimes we collect global data. And global data connects us with Puerto Rico many times. Puerto Rico's population is so much larger than ours, so it's hard for us to determine what is actually the data that we're looking at it from the Virgin Islands. Being able to include data that's locally extracted gives us more of an identity, gives us the ability to go back to grant writing. It gives us the ability to utilize that data to include that in our grant writing processes. So I think that we have a lot. It's just a little bit that we shared. And thank you so much for being here with us as well. But I think that we have so much more that we can share to you in the future. So Executive Director Michelle Francis, thank you so much for being, allowing us to be here. Going back to thanking you, Dr. Ford. I have been having wonderful conversations with you, like thinkers, so that's truly wonderful for being able to share. So each and every one of you that have been here today listening to us, listening a little bit more about what we do in the Virgin Islands Department of Health, we thank you.
Thank you. Before you guys leave, I do want to see if we've got time for about 2 questions. Do we have any questions? This happens every year. I find it funny. I think that's part of our culture. We're kind of like, no, we don't have questions. And then we'll come off to the side and be like, but wait, what had mean that diha sarat? Why does sarat? So I know you have questions. So feel free to pull Dr. Ellis, Dr. Megan. I'll say, Sudha, I think it's kind of hilarious. When I first heard your name, it was just Dr. Ellis was like, oh, well, Sudha can come down. So I felt like I was like, okay, yeah, Sudha. I know Sudha. And it's Dr. Megan, who's, I've appreciated your energy from the moment I met you. It was like, oh, you're Sudha. And I was like, again, thank you for coming down. Thank you for your energy, your innovation. I think there's so much more we can unpack learning about you. Thank you, Commissioner Encarnacion, for your team's involvement in a variety of ways today. Again, they're here on the ground, especially for those of you that are speakers and vendors and are curious. Please take advantage of the fact that they're here. That EPI report is so impressive. I think the first time I was kind of blown away, I think Michael's in the room. We saw the EPI report from last year, and we were like, wait, what? I was like, why haven't I seen this before? So very, very job well done, and I want to commend your whole team for the work that you guys are doing. So thank you, guys.
Thank you.
As we transition, I want to acknowledge Senator Bolkus, who's joined us from our 35th legislature. Thank you for being here. I think we're having a bit of an exciting transition right now, and this is very dear to my heart in a way that I didn't know it would be dear to my heart. It's dear to the strategic plan. The strategic plan for the Office of Health Information Technology includes community engagement. So that's empowering patients and providers. It's building the infrastructure, the digital infrastructure to enable better health outcomes. But then it's building the future workforce. That's one of the buckets of the strategic plan. Last year, we just mentioned that. And between last year and this year, through relationships that were fostered starting last year, and through being connected to some amazing people. You're going to get to hear about something that we just launched a few weeks ago that I want to see spread like wildfire. You guys have heard us say, and I believe Sudha might have even said it, Dr. Megan said it, when you look at the sustainability of all the things, the infrastructure we want to build, we can't rely solely on consultants coming in from the outside. When we talk about riding the wave of technology into the future, what have we done to prepare the future workforce? What have we done to upskill the current workforce? So the next 2 presentations you're going to hear, I think you're really going to enjoy and learn a lot from, because you're going to hear about our youngest and how they're being exposed to technology. And then you're going to hear about an amazing opportunity that is for upskilling our current workforce in partnership with Howard. So we're taking a little bit of a turn away from just talking about the technology, talking about the regulations, talking about the funding, to the human side of it, because at the end of the day, the technology is still empowered by humans. AI is faster than us, learns faster than us, but it's still about the humans that are here today. So Calvin Pinney, I'd like to welcome you to the stage. Calvin works with Google. Google introduced us. Ryan introduced me to Calvin, because he's like, oh, by the way, there's this Tomian that works. And I was like, a Tomian works for Google? Yeah, of course we want to meet him. And he's like, but more impressively, feel free to come have a seat for a second. More impressively, he said, have you heard of Breakbeat Code? No, haven't heard of Breakbeat Code. So I'm not going to steal its thunder. You're going to hear from him all about Breakbeat Code and how a Virgin Islander at Google is helping to prepare our youngest or expose them. Starts with access and exposure to opportunities to discover technology and build their own passion from there. So Calvin, welcome. It's been great getting to know you. I'm glad you are here in person. And I do want to mention Omni Systems and Zane. When they heard about this, Calvin was, he works for Google. He's like, I'm going to come in virtually. And I was like, Atomian, yes, we get that you can do it virtually, but the Atomian needs to come home and share this program. And so Zane and Omni Systems ensured that we got Calvin here in person. And so thank you for your investment and your passion, truly their passion. And the same, Dr. Carter sitting there, so I'm going to say this, Dr. Carter, who was our keynote speaker last year, will bend over backwards at any time, just always humbled by his incredible talent, by all of your incredible talent, to say, yes, what can I do? What can I do for you guys right now? How could we dream? How do we make things happen? So thank you for getting Calvin here. Calvin, take it away.
All right, thank you, Michelle. Good morning. So like Michelle said, my name is Calvin Pinney, Tomian. I grew up here, and I even have memories of playing basketball. Matter of fact, this very gym. And it is very exciting for me to come and talk about this opportunity, because when I talked to Michelle about it, there was a moment that I felt like, okay, is this going to resonate with her? Is this going to resonate with what people want to do here in the Caribbean? But she got excited right away. She got excited right away. One of the things she even mentioned, she said, like, well, just based off the opportunity you're talking about, Calvin, why can't we have our own little Wakanda in the Virgin Islands, right? And exactly, we can get a round of applause. So what I'm gonna start off is, I'll start off with my personal story. So growing up in the Virgin Islands, one of the things that was very passionate for me was playing basketball, because most of the people that looked like me were professional athletes making millions of dollars and doing something that they love. If you look at the statistics, only 0.03% of athletes actually make it to the NBA. The odds are definitely stacked against, hey, you wanted to be an athlete to take it to professional level. So one of the things that really got my interest with this, because I never thought in a million years that I'd have the opportunity to work at Google, but I made it a reality. I think why this program is important is because something that happened with the pandemic opened up opportunities where people realized that I can do the same amount of work that I do going into the office, and I could do it in another location. So the way I got involved in Breakbeat Code is about 3 years ago, and Google has what's called a 20% program, 20% project. So about 80% of the time they want you to focus on your job, and then 20% on a passion project. But for some reason I feel like Flip is 100% job, 20%, so you put 120%. But either way, this program has brought some interesting Gmail. Everybody probably have a Gmail address. This program Gmail came out of this program. And what also came out of this is Breakbeat Code. And what I was looking for opportunity to, when I saw the listing for Breakbeat Code, what got me really excited about it is, well, one, I have an opportunity to give back to the people in my immediate community, which that was in New York City. And I was like, wait a minute, this is a program that you could actually not only teach students how to code, but you could teach them to code with music. And if anybody know Penny last name, my family, that's all, they're big into music, Mandingo Brass, Willis Penny. And the next thing too, thinking about our Virgin Islanders or people in the Caribbean on a whole, music is a very central part to our culture. And one thing that I've heard here is that, especially when it comes to technology, unless you could humanize it and make it relevant, then to teach these type of skills is going to be very difficult. So, what I saw the opportunity, we did a hackathon in New York for New York City, Oakland, and Detroit. And when we did that, typically the students would come in to the Google office for this event. But with the pandemic, we ended up doing it remote. After we did it, that was the first event. And keep in mind, I didn't have any coding skills, but I was able to learn because the program was easy to adopt. And I went ahead and I taught some students from New York, Detroit, Oakland. And I reached out to the program lead after we did it. It was successful. We had about 50 students. I said, wait, hold on. If we're doing this virtual, how about we do something else with this? How about we take this to the Virgin Islands? And he was like, wait, Virgin Islands? I mean, ain't nobody traveling. I was like, no, we're going to do it remote. Same thing we did here, because you're doing this for underserved communities. And right now, when you look at the economy in St. Thomas, the Virgin Islands, we're very dependent on tourism. We have an opportunity to develop another industry, develop some talent, because kind of like me and like other people who probably went to school here, we end up leaving the island because there wasn't the opportunity. So we had to end up going to the States. But now you have people in the States that are coming down here working remote, and I'm like, okay, well, hey, how about we start right now? Because when disaster comes opportunity, and right now we have a huge opportunity to bring and uplift and rescale some of the students that are coming up, and even adults, right? So with that, that's just a personal story. I'm gonna just go into the agenda. So you could go next slide. Yeah. All right, next one. Okay, so the learning objectives for today is, I want everyone to understand why coding is a problem for kids, and why the traditional way, how it's been taught, what we've discovered in this Breakbeat Code program, how we've been able to be successful to not only make it easy to learn for students in North America, but all over the world. The second thing is, I'm gonna show 3 ways how Breakbeat Codes solve this problem for teaching coding to kids. And then last, what I'll do is I'll talk about the program for 2023, and then I'll let you all know how y'all can become a part of it. So imagine that you're in a class and you're trying to learn a difficult subject. This could be math, this could be learning a foreign language, and somehow it's tough for you to connect. It just doesn't make sense. It's hard for you to pick up. And one of the things that we thought about in Breakbeat Code is, okay, well, you have these difficult subjects, but instead of using the traditional way, how can we make these topics culturally relevant? How can we inspire and get students engaged, or even get adults engaged for something as complex, or for these complex subjects? And then the next thing too is, what if you're from an underserved community, when typically you don't have the resources, especially to learn something like this or be around the type of or to get that type of education. Next slide. So what we thought about, what really excited people about this program is, one of the core things is music, because music gives meaning. Technology without technology is technology, right? But the cool thing about music, and what I learned about expanding this through other parts of the world, is that music is central to cultures no matter who you are. No matter who you are. You could be in India, you could be in, you know, Trinidad, Tobago, you could be Native American, you know. Music is central to everyone's culture. And the cool thing about music, it also gives you, it gives meaning and gives you memories, and it's something that we all connect with. So one of the core things that we understood is, well, hey, music is a way to keep people highly engaged, and that's one thing that we definitely want to bring with the program, and definitely see how we could influence people to come into coding. The next problem that we had was, okay, we have music, we have the hook, we have something that people would engage in and be happy about doing, is how can we make this easy to adopt? Not only for the kids, but for the volunteers, because I got excited about this first just to be a volunteer. But I didn't have any coding experience, so we all went to the drawing board. We said, like, okay, well, how can we make this easy for someone like, you know, Michelle, if you want to go ahead and be a coding coach, you know, or Mr. Tucker, if you want to go ahead and, you want to go ahead and teach your son or teach somebody else. So that was one of the things that we thought about, and, how could we make it to where we could do this at scale? And then another problem too another opportunity that we saw is that, I had the foresight and the vision to take this program to St. Thomas, and to be honest with you, I think this was just going to be like a one-time thing. I thought it was just like, okay, well, boom, I'll do this on the island. But apparently, there were some other Googlers from St. Thomas that I didn't even know about, that heard about the event that I did, and they wanted to help. And what they did is, on top of helping in St. Thomas, they ended up taking it to Trinidad, Haiti, Jamaica, and then even some folks for Ghana, Kenya, India, Australia. And what was interesting about taking it to those parts of the world was the appreciation that they had just to have something that accessible, that they could be interacting with Google coaches. So I talked to you about, the problem that we set out to solve. For the last couple seconds, I'm gonna talk to you about the program. So I have a short video. If it could play, great. If not, I could just keep rolling. So, yeah, next slide. Okay, all right, we'll keep it rolling. All right, next slide. Next slide. So our vision for Breakbeat Code is to, by 2025, we want to teach and inspire 250,000 teachers and 1.5 million students historically in underserved communities around the world. This is a very ambitious goal, and that's one of the reasons, and it's really cool that we have the technology to do it, because we're able to do it in scale. That's why one of our strategic areas in the company obviously is Africa and India, because they have the population. But being that y'all have a Virgin Islander in Google, I'm making sure that we could get some priority in the Virgin Islands, because that's how we end up getting overlooked. But I'm here to see how we could get those resources to us. So if you see, I don't know if y'all familiar with Sway in the morning, but Shade 45, you have Sway. So to the right of Sway, that's Rich Nice. So I don't know if anybody know about Rich Nice, but Rich Nice, I found out, so I had a hackathon event that I was doing here in the Virgin Islands, and I found out last minute that Rich Nice, he's actually from St. John. So he was one of the, so typically what we do for the hackathons, we have a panel of entrepreneurs, music artists, and people in the tech industry. And Rich Nice, he was graceful enough to come on to talk to the students about why it's important for them to start learning these skills, and to not only talk about coding skills, but the brilliant thing about, I'll give some props to Apple. What I like about Apple is that it's very human-centered with the design and the products. They put people at the core. And the intersection between art, music, and technology, that's one of the core things to Breakbeat Code. That reason why we've been so successful. And at the end of our program or curriculum, what we tend to tell students is, don't feel like you have to box yourself in to just be a coder. Don't feel like you have to box yourself in just to be an artist. Why you can't do both? So, next. And in our curriculum, one of the 3 themes, especially that we've seen more so through COVID, is 1, creativity, collaboration, and problem solving. At Google, we've been working remote for forever now. I mean, the pandemic hit and people were working remote, but most of my teams don't even work in the office that I'm at. We work all over the country. And one thing that, especially being in the Virgin Islands, that we should be comfortable with is working with the collaborative technology. So we saw Breakbeat Code as an opportunity for people to work in a virtual environment. And what's interesting about the curriculum is that if you're familiar with Google Docs, where you could sign in real time, you could work in a doc at the same time with anyone around the world. With the program, when you're coding, you're actually coding with students. You could be coding with students from, say, New York, Florida, or make it more real, St. Thomas, St. Croix, St. John. You could all be coding in that same doc together, which it gives you that collaborative experience, and it also allows you to develop those problem-solving skills. Thanks. So, yeah, that's me. That was the first hackathon I did for St. Thomas. Pretty much what a hackathon is we have a panel where we have artists, we have entrepreneurs, and then we have people from the tech industry come in to talk about their experience from growing up to how they got to what they do today. So that's the inspirational part. And then another part to that is where we do, we break everyone up into groups, and you have a group of 4 students that their goal is, a group of 4 students with a coach, and their goal is to creatively put together a song together. So at the end of the hackathon, everyone has the opportunity to play the music that they created. And I actually have 2 songs at the end that y'all gonna be able to listen to from some of the students that created music from the event we did last week. So who's adopted Breakbeat Code? So we have teachers, we have schools, school districts. Recently, we just did a program with the Boys and Girls Clubs over in St. Croix. We also work with nonprofits. We did an event with the Chambers of Commerce. That was Chambers of Commerce and Children's Museum. That went really well. One of the first events we did was with G Clef Music Academy, and those are the people that typically come to us to bring this to their community. So I'll just go ahead and show you how you can bring it to your community, and then if you have time for questions, then ask away. So there's 3 ways that you could bring this to your community. One, what we did last week is we co-hosted what we call an hour Breakbeat Code. This is where we have one of our Google coaches run a session with you. Typically, we have like a partner that could align resources and get all the students registered on their end. This is a virtual event. Typically we've done it virtual, but now that everything's open back up, we've been doing it hybrid, right? So the best way to do this is typically having someone on the ground with the students, and then you have a virtual coach from Google. However, people, being that you're just doing this online, like the students could just be at home or wherever they're at, right? To where they could get involved with the program. The next thing too is, you could do the Breakbeat Code hackathon, similar to what I did with Chambers of Commerce. And then the last thing too, which we're trying to get up and running here in the Virgin Islands, is bringing a summer program. So the summer program is anywhere from 6 to 8 weeks. And with a summer program, typically what we would need is a program manager, and then for the program manager, we could have 2 coaches, so that would be a lead coach and assistant coach. I've done this with the last program that we did was with Trinidad and Tobago. It was awesome. We have on our website teach.breakbeatcode.com, where it gives you the whole template on how to do it, but I have people on my team that would walk you through the way on how to bring the program, whether it's a nonprofit or after-school program. And that's the QR code. One thing that I would do before I wrap, I have some of the music that we made from last week. If you want to cue that up, and then also, I don't know what order you want to do it in. We have the video and the music, so we could play that when you're all ready.
Good afternoon. Today we launch in the Virgin Islands Breakbeat Code, an application that is going to teach our kids, our young people, how to code in Python through beat making. The office was a year old. It was our first conference, but the strategic plan guides and has always guided the work of this office. And one of the strategic objectives is to meaningfully engage young people in ways that show them a potential future through technology to express themselves and their God-given talents. Calvin Pinney, I was fortunate to meet through the relationship we formed with Google last year when they came to the summit. As we continue to engage with them about problem solving for not only health IT, but for how we train our local workforce, they mentioned that there was a young man working for Google named Calvin Pinney from St. Thomas. So of course that piqued my interest. And then I found out that he has a program called Breakbeat Code that teaches Python coding to kids through beat making. So what more engaging way to learn to code than not feeling like you're learning to code, but you're having fun making beats. My office wants to continue to build strategic partnerships with companies like Google to find unique and engaging ways to bring our young people in. We've got relationships with Microsoft. We have VINGN right here in the territory. The hospitals have unique programming. We want to work with everyone locally and off our shores to find out how we can more effectively excite our young people around technology and all things STEM. We've got some fabulous young people here today ready to go. Anybody have coding experience in here? So we've got a lot of novices, and we're excited to introduce you to the folks who will be coaching you. The cool thing is that our coaches from Google are Virgin Islanders. You get to see how you could follow in their footsteps, and I'm not gonna steal any of their thunder. I'm gonna let Calvin and Estelle jump in and share what you'll be doing today. But my office, the Office of Health Information Technology, is very proud to be bringing this kind of programming to our young people so that the future truly is your oyster and you feel like there's nothing preventing you from doing what you want to do.
All right, thanks. And we got a couple tracks from the event that we did, so we'll just go ahead and play them for you, and then we could wrap. Hey, hey. All right. So, thanks everyone. If you I'll be around if you want to learn more about the program, but it's been a pleasure coming out to talk to you about this exciting opportunity that we have. Thanks.
So first, again, thank you very much, Calvin, for being here. And so I get made fun of for choking up. But this was done in like 2 hours. So if our kids could do this, what you heard in 2 hours, Wakanda is possible. So it was amazing to watch their faces, because when they were hearing Calvin and Estelle and one of their team members, and they were like, okay, so now open, and you see all this code and like go down the list, and they were all like, wait, what? And so I was like, oh boy, is this possible? And then by the end, they were like, yeah, listen to what I did. So it was, and he felt the confidence that I was kind of like, Calvin, you sure this is gonna work? But if that's, again, what we could do in 2 hours as just a test pilot for wanting to see this pushed out. And again, the reason that we want to push this out is, as Calvin said, we don't want to narrow the scope of what our people can do, and we want to not only bring in talent from the world to solve our problems, we want to bring our talent back home to work on solving our own problems and building the future companies, coming up with the solutions of the future. So again, find Calvin. I want and hope to hear of any programs that any of you are connected to. I want to highlight Daryl Wade, and I know he's going to hate me for doing this right now, but Daryl Wade is an understated talent here in the territory. But Daryl, thank you for the introduction to the folks at Google that fostered this relationship that ended up bringing us here. So I just want to recognize that you sit there quietly, but he's brilliant, a brilliant mind, and just a very hardworking person with zero ego. So thank you. Make sure you get to know Daryl, please. But thank you again, Calvin.
All right. Thank you. Very well.
Thank you. So continuing in this vein so that I can get you guys to lunch, you're going to hear about something else inspiring, which is another opportunity we have ahead of us to upskill our current workforce, which is necessary. So we're on the fast track to implement digital tools that help us achieve outcomes, but then it's like, but wait, we only have one person in our department that does anything with computing, and that was a bachelor's degree they got 20 years ago. And so then we're like, what do we do? And so even in the hospitals and the FQHCs, as they're upgrading their electronic medical records, you've got a willing workforce, but not necessarily a prepared workforce for the tools of tomorrow that we are currently using. So I would like to welcome to the stage Dr. Mary Awanda. Please come up. Dr. Sandra Ford again. And for any of you who were missing, Dr. Sandra Ford, our keynote speaker, had so much to share yesterday. I hope you've taken advantage of the opportunity to talk to her. And Mr. Luigi LeBlanc, our Italian Haitian. And Luigi, where were you during the sock competition? You didn't wear socks today?
No socks.
Okay. Please go ahead, and you can all sit on this side. First, Dr. Awanda is just going to share with us a program, the Public Health Informatics Technology Program in Washington, D.C., in Howard University. She's going to unpack how they have partnered with businesses in the community, technology companies to create, and with the Office of the National Coordinator, I believe some of the funding came out of the ONC, to create a program for upskilling at no cost. So without further ado, Dr. Awanda, again, just another, I must say to all of you who I've had, and I know Eddie and Evernie feel the same way, and Joanne, the lack of ego in the crazy talent that we've been able to interact with, to pull together. I just want to thank you guys for just being humans first and caring, and then being flexible to work through all of the kinks of what we're trying to do here. Thank you guys.
Oh, good. Yeah, it's still morning. Good morning, everyone. Again, my name is Mary Awanda. Glad to be here. And my charge today is to bring greetings and good information about our public health informatics and technology program that we initiated about 2 years ago, September of 2021. Next slide, please. Next slide, please. So I have no disclosures for this presentation. Next slide. So what is the Fit for DC program? The Fit for DC program is an ONC-funded grant program to the tune of $8 million that was given to the University of the District of Columbia as well as Howard University as two HBCU anchor institutions. And the goal really was to increase the number of minority persons who are trained in public health informatics and technology. The pathways are co-led at Howard by both the Masters of Public Health programs and the College of Pharmacy, where my current faculty appointment is. Next slide. So these are our program objectives. I'm not going to go through them one by one, but essentially what we promised was we were going to build a consortium. We were going to make sure we build a community-sensitive curriculum, that we were also going to play well in the sandbox in terms of two anchor institutions and set up infrastructure that will be able to recruit underserved persons into our program. We also wanted to make sure we had equity transfer opportunities, so if you had credit from one institution, you could transfer it to the other institution, and also give credit to people who've had prior experiences, hence this upskilling component of our program, and then ensure that our scholars had hands-on training via internships. Next slide. So here's our mosaic of collaborators, and I can say quite frankly that we really wouldn't have been able to do this without them. Academics we're notorious for falling in love with our own ideas. Like, oh, this looks great. But, our partners have really been able to check us. And so you can see our consortium members were CRISP, who you heard from earlier, the DC Primary Care Association that helps support the FQHCs, the Federally Qualified Health Centers, and also ZANET. And they've been able to help us build a really industry-focused and locally centered curriculum that really is going to have impact. So I think the narrative here is that all this is for naught. This wave of transformation is all for naught if we don't train people the right way. And I think what we really wanted to do was to be intentional in how we built a curriculum to make sure that we were building people who were ready, shovel-ready to make impact in their communities. Next slide. We also had an advisory board who are leaders in the community, again, who could help us make a sustainable model for our program and also connect us to other places in the community where we as academic institutions wouldn't have been able to go. So I want to acknowledge and thank them for their roles in supporting our program. Next slide. So here's a summary of the training program in terms of the innovation points. And sometimes, we call it innovation, but sometimes it's really just humanization of our curriculum, honestly, making sure that it's really going to do what it's supposed to do. The first thing we wanted was multiple points of entry. So whether you were a career starter, someone who's just starting out, or you were a career changer, you want to upskill, or you were someone who was wanting to advance yourself, or you were an expert, we had everything for everyone and wanted to make sure that we were inclusive in that way from day one. And even for the career starters, and I'll share a little bit more about that pathway, we also incorporated a boot camp component for those who may have felt some discomfort in kind of joining in the healthcare workforce because they had no prior healthcare experience. So multiple points of entry was something that we felt was a real point of innovation. Second thing is we wanted to address social needs of our students. I think there's a lot to be said about social determinants of health, but there's also social determinants of completion of your education, right? You find yourself in a different housing situation, that disrupts your educational experience. You find yourself food insecure, that also disrupts your educational experience. So we wanted to make sure that we took care of our scholars from day one. If we truly wanted to recruit persons from underserved communities, we had to make sure that at intake we asked these questions and then directed them to local resources so that they would be able to complete the program. We also wanted a program that was community engaged. And, you know, the term sounds great, but it can often be checking a box. I'll share a story. One of the very interesting things we did was we took our curriculum to our Ward Health Council. And the Ward Health Council, they're a tough crowd. You know, so we were there, we thought, oh, you know, they're gonna love us. So they told us, you know, this is not good, where's more of this, where's this? And they were very intentional about, and we also had to take some heat because they said, you know, there are programs that come here and they say they're gonna do all these great things, and then when they leave, they do nothing. So we had to take the blame for those who had preceded before us and were not intentional or honest about their goals for the community. And you know, we were able to even recruit speakers from those who were critical of our programming. And so sometimes those who are most critical about your programs actually can turn out to be your colleagues and friends. So that's one of the things you know, we really felt was a good point, was community engagement. Also, the next two bullets just spoke about, we wanted a curriculum. We and our consortium members, ZANET, CRISP, we wanted a curriculum that was going to speak to the new changes that were going to happen in our community. Almost kind of where USVI finds itself now is that you're about to implement an HIE. And so, you know, DC was far ahead at the time, but they were, you know, not a lot of people knew what CRISP was doing. And so we wanted to make sure that we were training scholars to be able to function in this new environment and train them in these new skills. And we also wanted to make sure we were aligned with our state health IT Medicaid plan and also our digital health competencies that had just come out. So our curriculum was mapped to things that were real and not things that, because I think it's absolutely unfair to train someone in something that's not going to be relevant. So we wanted to make sure that we wanted to train folks on things that would be directly relevant to helping in the community. And I already spoke about the boot camp, and we also developed a team project with our Department of Behavioral Health. So the students had to actually think through a project that allowed them to think through how to navigate and care coordinate using these tools. Next slide. So here's just a summary slide of the different career pathways we had. So we have the Career Starters pathway that I said is a boot camp. We also have an abbreviated curriculum planned for direct support workers or peer recovery coaches that's a lot shorter and more task focused, and that's supposed to launch in August. Our Career Changers and Advancers core course is the one that it's actively available. And the focus is it's a 15-week virtual course that, again, introduces folks to public health informatics tools, expands on this idea of interoperability in a very practicalized way. We provide hands-on training on the HIE, so in our case, CRISP DC, showing folks, you know, the different platforms and available tools. And we also have a 3-day training on an EMR, and we were very intentional in which EMR we picked. We picked an EMR that is highly utilized in most of the ambulatory care clinics in DC, again, with a focus on having an impact in DC. And then we also wanted to leave folks with an opportunity to get a certification. So our training was mapped to and led to a boot camp that could give folks an opportunity to sit for the KHIMSS certification. And then for our healthcare professionals, we have a patient-centered medical home training and certification program that's ongoing, and that's for more of our seasoned practitioners who want to have their practices be a patient-centered medical home so they could bill for at higher rates, and also, again, provide better care coordination for patients. Next slide. So by the numbers, so again, as was said before, you know, when you're going to promise things to grants, you have to promise what we're going to do. So we promised 500 trainees, and we can say we've been very, very fortunate. Thanks to our approach, we've have 180 trained so far. So we're really on target to meeting our goals. Next slide. So exciting for us is an expansion of our program to the USVI. So we are actively recruiting from folks who want to upskill specifically for our 15-week semester course. It's through an exchange program with the College of Pharmacy, and so once you apply and then you get entry into our 15-week semester course starting in the fall semester. So anyone who is interested in participating in the program and getting the core competencies on the HIE, on interoperability and all the public health informatics tools are very, very welcome to apply, and I'll be happy happy to speak to anyone who would like to participate in the program after our panel. Also exciting is you had Commissioner Encarnacion speak about her community health workers. We are also planning a program to upskill the community health workers on these additional digital tools, and so we're very, very excited to partner in this capacity. Next slide. So being a data person, I struggle with giving data or giving you sort of the soft measures of our program. So my softer side won, and I just wanted to leave you with some quotes from our students who participated in our program. You had people who said, I didn't know what an HIE could do, and you had people who said, I had no idea this is how health IT, impacted us so much. And so, I think it's so important, and I think it really needs to be said in these forums, is that anybody can learn a lot of this stuff. There's sometimes an intimidation factor that comes with when you hear all these big terms mentioned today. But I'll take a quote from Dr. Carter, who teaches in our program and who was a keynote last year. He said, if you're willing to learn some stuff to help some people, you can make it happen. 4 years ago, I knew nothing about interoperability and all the things that are being mentioned here. But, look at me now, right? So it says the power of wanting to learn something to help people is a huge driver for transformational change. And sometimes, you're going to be the next man up. You're going to look behind you, and you're going to be the person who has to make change in these areas. And so it's really, really important for us to make changes and to want to do better by our communities. So I'll stop there and turn it over to Dr. Ford.
Well, hi everyone, how are you? Luigi LeBlanc here. I'm Vice President of Technology at Zane Networks, but they often tell me I'm the Chief Problem Officer. So I create a lot of problems that we got to figure out how to fix, but they're worth fixing. And so I think Mary gave a great overview of this program, and you would think that bringing two HBCUs, Historically Black Colleges and Universities, together to focus on a common goal, which is to upskill and train diverse minority populations to meet that goal, is an easy task. But I think naturally you have coopetition amongst institutions that are in the same geographic location. But they stepped up, they came together, they wrote the proposal together, deans came together, Mary and others came together and wrote this proposal for the betterment of the district. And so it's encouraging that we're here, and I heard the Commissioner Encarnacion talk about collaboration and cooperation and being able to work towards that common goal, because that's what it takes. And that's what it's taking in the district to be able to implement this program. This program also from the beginning, as the Department of Healthcare Finance, which is the district's Medicaid agency, was preparing for a strategic plan to transform most of its healthcare organizations who didn't get the benefit from the high-tech dollars which proliferated electronic health records. So those are your home and community-based service providers. As they saw that coming, and those organizations were being carved into managed care in 2024 and 25, they really wrote a blueprint for upskilling these organizations and their staff, because they previously were dependent on government systems, billing through invoices, and now they were going to have to be more accountable. They're going to have to extend their services beyond the practice into the community. They're going to have to screen for those social determinants that Dr. Ford talked about and capture those data elements that are really important in terms of gender, language, and ethnicity. And so they were the catalysts and supported it and brought together the Hospital Association, the Behavioral Health Association, the Departments of Health, to all not just participate in what should make up the curriculum, but also to be guest lecturers and speakers into the curriculum so that the students can hear from the community leaders who are making change happen. And so that was really, really important. I think Mary alluded to the fact that we had to have, when you're putting a program like this, you have to have the trust of the community. And so you've got to go into the community and you've got to get those punches. And you've got to be able to withstand that and come out with a working plan that really will be sustainable. And so what we did is we found a champion that had the trust in the community, Calvin Smith. and he became the advisory board chair for this group, and he assembled a group of stakeholders that represented the real residents of the community. They're the advocacy group, the policy side of it, and also those who were funded by the city to help make sure that people can move up the socioeconomical ladder. We also brought in the Workforce Investment Council, and so the Workforce Investment Council chair challenged the group because they said, you know, we look at students who are in college and university, they're on their way to success. And so we want to make sure that you're including those that may not see college and the anchor institutions as a pathway to success. And so they challenged us to look at things that are really tough to do, returning citizens. So how do you get those who are returning from incarceration back into the community to integrate properly? And one of those things that they have to do is to have jobs, and they have to have meaningful employment. And so, and part of that was challenging to do in the district because there's a persona out there. At first, we thought it was baked into legislation, but it's a persona out there that that said that you can employ a person who had been incarcerated. And so, as a result, that was a barrier. And in fact, even us as a small business, when we're employing new individuals, we do a background check. And so that became a barrier. So they really challenged us to do that. The other thing that was really exciting is reaching younger, and it was great to see Calvin in his presentation about breakbeat codes, reaching down at the high school level and trying to get gender diversification amongst those who want to see health IT, and even though it's got the IT side of it, young boys often don't think health is a profession they want to go into. So when they see the technology side of it, when they touch those tools and they can see the data, the analytics and its impact back into their community, that might create a pathway into employment. And what we're seeing amongst the young, the individuals who are at the graduate school, at the School of Pharmacy, public health school, what we're seeing with those individuals is that when they take the course, because they really want to go back into the community and do such things as become community activists, advocates, community engagement specialists, and really help residents, us as patients, be able to navigate the system and be empowered to navigate the system, leveraging these tools that are out there. So those things really, really, really mattered. And you couldn't create a program like that in a black box. There can't be a magic box, and outside, at the other end of the box is this solution. It has to be an open process. It has to be open to change. It has to be flexible and agile in that way. And what's really important is also, this is a program, the way the federal government funded this is not a grant, it's not a contract, it's a cooperative agreement. And what that means is they're partnering with you, they're really part of the team, and every 2 weeks you're meeting with them and they're looking at the program, they're looking at the models, because they want to catch it early on where you may not meet those goals that we stated we're going to meet. They bring the evaluators in to make sure that we're not just hitting the numbers. So we said 500, but who are you training amongst that 500? Where are they coming from? What zip codes? So those things matter. It's really good. They'll bring expertise from industry to tell us what's needed. So we learn from big firms like Apple that what they're looking for are project managers, and not just people who can manage tasks, finances, and to get the project done in time, but really manage people and deal with conflict so that you can get to the goal together and lead properly so that this is sustainable. I also learned that data analytics is absolutely important, and this has been a week of a discussion around data. And so, and it's true. If you can't demonstrate the outcome, then it's not good enough to say I'm doing good work, or I'm serving people, and my patients are well, or my residents' well-being as well. You got to show me the numbers, and that's really important. And so that's what the employment side is looking for. Another part of this program that's very important is it pays. Does it a paid internship? Pays a paid internship. Because we're reaching individuals who come from Ward 7 and Ward 8 in the district, and I think Mary talked about that's where the outcomes are the worst, the disparities and the inequities exacerbated there. And so you're paying these individuals to come get this skill set, And then we're advocating with the employers to hire them and to give them a wage that is a livable wage. So I love what the commissioner talked about when she talked about moving from community health worker to, did you say engagement, individuals who are doing more outreach and engagement. And so we want the workforce to recognize their new skills and then give them that wage so that they can live, learn, and spend in the District of Columbia.
So this program gives me so much joy. First of all, just from the highest level, representation matters, and I can't say that enough. The fact that they are selecting previously incarcerated, I mean, that's a population that rarely get a second chance in this nation, and so that in and of itself makes it transformational. That also goes back to what we talked about yesterday and today, which is trust, because that's a population that people tend to be wary of, and there's a lot of circumstances around how people end up being in the system that may or may not be fair. And so to have an opportunity to give them the chance to redevelop in a sense is very powerful. I'm also excited because when we were developing the White House Action Plan on the Social Determinants, ONC was our #1 ally. And so one of the things we did was ask the different agencies, what can you commit to help drive this forward? And a lot of what we got, to be perfectly honest, was sort of fluffy, or things that they had already been doing that they just put in there so we could say we checked the box. And so we kept pushing back. No, not stuff you've done. What are you gonna do new that's gonna move this social determinants, health equity issue forward? And so ONC said, well, we're going to train these folks and give them the IT skills that you say are lacking. And so we were like, okay, but how long is that going to take? And for sure, do you have money for this? And so to see this actually be in operation, it just makes me really happy. And very excited to see how this moves forward. There's a couple of common themes here when I look at, when you talk about meeting people where they are, we're back to equality versus equity. Now, you could have created a program where everybody got the same curriculum and they would just have to figure it out. But we know that adult learners learn differently, and so you have to meet people where they are. And so the fact that you have this tailored and customized to meet people's needs is also really important. It also speaks to what I spoke of yesterday, which is that knowledge gap of IT that is going to cripple us, because we have to make sure that the skill sets for technology match the needs. And right now, it's a huge gap, and that's an honest observation, and that's across the nation, and certainly for public health. And so the fact that that's being addressed and being focused on real time is going to be a game changer, because we can't move forward until folks know how to work these systems, and we get out of spreadsheets and things along that line, because we have the technology, but if we don't know how to use it, you know, it's not helpful. And again, back to the analytics of, are we doing this correctly, and not just how many people did we see, but what was the outcome? How did this work for them? Well, how is this going to change their lives? So for me, this is sort of everything that I think about when we were putting together the action plan and actually seeing it boots on the ground is really exciting. And it also highlights the fact that there are no new inventions, and we said this, like, we weren't trying to invent initiatives that were going to drive social determinants, because we knew that they were already being done at the local level, and the issue was really, how do we highlight what's already being done that's amazing and expand it, or support it, or multiply it. And so this is a great example, and I would love to see this across the board, you know, in other colleges, because we have gaps all over the place, but I love that the target for this one was HBCU, because to want to be something, you have to see it. And so to see, former incarcerated young kids doing this type of work, it gives people the idea that, hey, I can do that too. Because we are so locked into careers sometimes with our kids and our young folks that you have to be this, this, or this, these 5 categories, and there are no other opportunities. And the world is changing daily. And so having the opportunity to share all of these different, types of things that our kids can go into, or adults that may be starting over can go into, is a very positive and encouraging thing. So it's very exciting.
I would, to Dr. Ford's point, when we came here, I came here a couple weeks ago with the National Medical Association, and I had an opportunity to visit the VA center right across from the hospital, the VA clinic there. And what I learned is that Virgin Islanders actually serve in the armed forces and actually serve at the career level, so 20 plus years. And then we met with the Dr. Whitaker and also his wife, who's an OBGYN, and visited the facility, very nice facility, but he shared like he was one clinician with one nurse practitioner and one RN that was serving 800 veterans. And so when we were doing the workforce program, one of the advisory board members was a former military individual who also represented the federal government, and she challenged us to make sure that the curriculum was reflective of not just the demographic that we're talking about, but also veterans and those with disabilities. And she said that, oftentimes, and we actually made the mistake. We created the flyer, so we changed the flyer, one specific to veterans, and then another one specific to disabilities. And on the disability side, we put someone in a wheelchair. And they caught that, and they said, well, that is not, so that's the stigma around disabilities. And so you have to learn to the point around cultural competency. You have to learn the population, and if you want to get individuals, diverse individuals, to be part of this transformation that the territory's going to take, and is exciting, and it's so exciting the work you've been doing. We just have to keep in mind diverse populations and how they can participate. Any questions?
Not necessarily a question. I want to give you a little update. We have a team of 10 right now that's sitting in DC that's working with the Director of Veterans Affairs, Director Patrick Farrell. He and I are actually on the Governor's Challenge to reduce suicide rates within the veterans. And as a result of that, we're expanding our services, working collaboratively with him. So I think that just linking him and the veterans and the services that's being provided is actually, because it's a very small office that he has, and the physicians and how we actually integrate or interact from a healthcare perspective is actually going to be expanding now because of the collaboration that we're doing together. So making a difference.
Five, 10 minutes. Are there any other questions from the audience? If not, maybe we'll just give you want us to give some closing remarks?
Again, I just want to extend our sincere appreciation to Director Francis for engaging us in this process. I'm very passionate about training and education. I'm very, very passionate about being a lifelong learner and not stopping. Because it's important, because the world changed. Who knew after pandemic that I would still keep my job in academia? I had no idea. I was like, maybe I need to get a certification myself, which I am going to get, thanks to Luigi and his friends. But again, the charge is no end to upskilling My dad used to say, if you don't upskill, then somebody 10 years younger than you is going to become your boss, and see how well you like that. But we are very excited as an HBCU to partner. And I'm so delighted to be able to have the opportunity to expand and continue to train. So please seek me out if you are interested, and we'll still be here on another breakout session tomorrow, I believe. But again, thank you for the opportunity.
My first pediatrician was a black man who I thought walked on water. And so that's probably why I'm here today as a pediatrician. And so it highlights the importance of seeing somebody who looks like you doing things that you might be interested in. And so these kinds of initiatives are very powerful. So I hope to see more of that. And I'm very happy that this is being supported at the highest level. More.
My commitment to the territory after listening when I first came here maybe 2 years ago, listening from you all and hearing about what you're doing and how you're leading change is what continues to inspire me to come and bring others to do the work. You can't have the governor talked about being a digital governor, and you could see it with the spirit of what's happening in these rooms. And we, who are outsiders coming in, believe it. And so part of what we have to do is commit, but we have to also be ready to participate, contribute, employ locally. And you can't have transformation without coordination. So just like we talked about the Office of the National Coordinator, the Office of Health Information Technology doing this work and coordinating everyone around the common goal is going to be critical to success. So I am here to stay as long as my boss tells me I can continue to make problems. And thank you all.
Thank you so much, again, for your talent, for your expertise. And we're looking forward to seeing this launch this fall. And I know Dr. Awanda didn't mention, but there's other opportunities that aren't the 15-week course. They have some boot camps that they'd like to do. So especially within our hospitals, our FQHCs, our Department of Health clinics, do talk to Dr. Awanda, because if you've not got a cohort ready for a formal 15-week program, she's willing to talk about some of you saw it on the slide, about the boot camp opportunities to just really start to engage your staff, get them excited, and get them skilled. And it's free. It's free. When we talked about the cost of this stuff, let's take advantage of what is free. So again, thank you guys very much. I will mention, you don't have to leave the stage because we'll be going to lunch after this, but I want to mention, I don't know if Dr. Luciano is still here, but there is a Women in Data global organization that has launched a chapter here in the Virgin Islands. So if Dr. Luciano is still here, or I believe Dr. Blair Jackson, if she's here from Schneider Regional, no, from JFL, reach out to them to find out about the Women in Data chapter. I also want to highlight the RT Park. And I don't know, Sydney, if you are in the back of the room. If you are, please make your way this way. And I do this to Sydney because I can. I'm taking a liberty. But I want all of you to get to know the research and UVI, University of the Virgin Islands Research and Technology Park. They offer a broad array of resources and support, and they also offer benefits to technology companies looking to expand and relocate to the Virgin Islands. So please make sure you talk to the team. You'll hear from them tomorrow. But please make sure you talk to, you'll get to see who you need to talk to. All right. Sydney Paul. I've known Sydney since Sydney was very young because her mom was my boss and my favorite boss ever. Still one of my favorite people, Senator Maurice James. Sydney has just followed in her footsteps, a powerhouse doing amazing things. So again, please make sure to visit them at booth number 2. 3. 13, sorry, I was way off. Booth number 13, but it's towards the back wall. So I know you guys must be very hungry. I would ask that we come back. We're going to have a very exciting panel when we come back. We're going to be talking about AI. We're going to be hearing from someone who's been featured in National Geographic for her work in AI. We're going to be hearing from Damon House again, who came third runner-up in the SOC competition. But we've got a very exciting conversation. ChatGPT has us talking, so eat, but come awake and come back at 1:25 so that we can get going at 1:30 and get you out of here today. Thank you.
At Schneider Regional Medical Center, we are dedicated to providing high-quality, compassionate care, and we are constantly focused on enhancing the patient experience. Our organization is embarking on an exciting digital transformation. We are adding new, cutting-edge technology and, in many ways, transforming healthcare for our community. We are updating our electronic medical record, and we are preparing to participate in data exchange with other providers. We are implementing new clinical equipment and expanding our use of telemedicine to create new access to specialty care for our patients. Our staff and our patients are at the heart of everything we do. We are working to make Schneider Regional the best place to get care and the best place to give care. The changes that we are making within IT at our facilities will enhance both our staff's experience and our patients' experience. As we rebuild and modernize our facilities, we are designing for a brighter, advanced future where we use the latest innovation to help us deliver the best care to our community. We look forward to continuing to work with the Office of Health Information Technology, with Director Michelle Francis, and with other stakeholders to continue to advance health IT in the Virgin Islands.